Guys, I'll be honest with you. Most people leave this topic, but since you have come to this topic and are hearing me out, I can assure you 50% battle to is already won. For the remaining 50%, if you sit tight and hear me right till the end, at the end of about 4 plus hours, I can assure you that you'll be able to do precision strikes. That means that I'll be teaching you those keywords which matter for answering in neurology, because cardio neuro, I think, are two topics where no bluffing is possible. Either you know it or you don't know it. Okay, so let's move on to the first topic here, that is seizures and epilepsy. Both of these terms are used interchangeably, but obviously epilepsy basically means tendency to have seizures. So one very general kind of a question was asked in FMG exam, that a patient would be having how many episodes of seizures. I mean, because I said epilepsy is a tendency, so said more than how many episodes of seizures should be occurring in a patient to call it epilepsy. Then you need to remember more than two or equal to two episodes of unprovoked seizures. Mark my words there. I also said the word unprovoked. That means, like, suppose somebody is having hypoglycemia, then I'm not going to call it an epilepsy. Now, then I'll only call it a hypoglycemic seizure. So, I mean, metabolic causes have to be ruled out. So, he created various options like more than two episodes of provoked seizures, more than two episodes of unprovoked seizures. What you have to understand is that metabolic causes should not be there. And one of the overall number one cause of acquired epilepsy in India is neurocysticercosis. Yes, guys, when it comes to NCC, we'll be discussing this topic subsequently, but I can say that the eggs of Taenia solium, when they reach into the brain, they result in formation of these hypointense lesions with the scolex. And these lesions will cause vasogenic cerebral edema. And that vasogenic cerebral edema, when it irritates the brain, it causes development of seizures. So a lot of patients in India with GTCS or focal seizures could be having neurocysticercosis. So we'll discuss the neuroimaging findings of this parasitic infestation and when the time comes, and it's a disease of the low socioeconomic strata of the society. And you anyway know, like, vegetables in India, you know, cabbage, lettuce, all those like products that we consume in salads, they should be washed very properly. Otherwise the person could end up with ingestion of proglottids containing eggs of Taenia solium, and the person can end up with a neurological complication. Then before I describe like the types of seizures, some questions that you'll get in various apps would be like on baseline data. Like if your eyes are open, like at the moment you are listening to me, so your eyes are open, you are all like alert. So the rhythm that is present is called as beta rhythm, and the discharge frequency of this would be more than 13 hertz going up to 30 hertz. So our brain is like firing on all cylinders at the moment, and you are all attention. Now suppose I asked you, doctor, please close your eyes and relax. You know, like when we do yoga, yoga is supposed to relax you. So when you close your eyes, you lose contact with the outside reality, partially because like eyes, I can say, are giving us so much of information. Now the moment you close your eyes, you will notice that your EEG pattern will change, our brain will relatively slow down. That's when, like, lots of time when we are tired, subconsciously, you know, we may close our eyes because we are like overwhelmed by so many things happening in our life. We just close our eyes and we try to give rest, and that is the time when our discharge frequency will become relatively lesser. That is in the range of about 8 to 12 hertz. So what I want to say is that beta and alpha should be remembered, and one should not, you know, swap the data, because examiner will try to, you know, give a question where, like, I can say in exam, no, you have to jump from one topic to another. So lots of time people have seen they swap the data alpha plus beta. It is beta that is having a higher frequency and not alpha. Then are three questions on EEG which are like must know for you. The first one will say less than 3 hertz spike and slow wave pattern and multiple seizures types are seen in. Now the commonest error that I've seen here is that on reading the word 3, that's why I kept it in red, a lot of people casually answer as absent seizures. Well, the point is, one, it is written less than 3, and second, it is written multiple seizures types. In absent seizure, it is only one type of seizure. Now that is the vacant staring spells that are seen in a child. So if you are having multiple seizures type present in a patient, like GTCS is also there, atypical absence seizure is also there, then we have to think in terms of a condition that is called as Lennox-Gastaut syndrome. So if he gives you a question where the number given is 3 per second, spike and slow wave pattern, then you answer as absence seizure. Like this is one of the commonest EEG patterns that will be given to you. You can notice some background rhythm present. Like this background rhythm can be alpha or beta depending upon the discharge frequency, whether the eyes of the patient was open or closed. But then you are noticing a sudden slowing. And at the moment, what I'm writing is 3 hertz. You see, earlier I was saying the word less than 3. Sometimes you may write the word 2.5. Now 2.5 will make it easier for you. So a lot of these questions, they mention less than 3 hertz. And then the second time they will mention the word 3 hertz. 3 hertz means that in every 1 second, 3 such abnormal waves are being detected. These abnormal waves are being detected. So 3 hertz spike and slow wave pattern. That's when you encounter and the question says like what is the diagnosis, your answer would be given as absence seizure. This is also called as petit mal epilepsy. I'll be giving more inputs regarding absence seizures as we progress along, but at the moment I'm focusing on the drugs that can be used. If he says what is the drug of choice, your single best answer is ethosuximide, which is used in pediatric age group. In older age group we can use valproate, and the third drug that can be used is lamotrigine. So nowadays they've stopped asking questions like what is the drug of choice for absence seizure, that everybody knows is ethosuximide. What he started doing is all of the following are useful in management of absence seizures except, then your answer would be like these are the three which can be used, that is ethosuximide, valproate and lamotrigine. Now, when you focus on the EEG adjacent to it, I'll use a different color. This looks like I can say some, seismic graph, like as if there is some earthquake happening. I mean, it's all chaotic pattern that is present here. So the term that I would like to use here, because it looks like an earthquake happening, is called as Hips arrhythmia. Now, first time when you read the term Hips arrhythmia, it looks like as if it is some cardiology question because arrhythmia is related to cardiology. But this Hips arrhythmia is the only term in neurology where actually it's not a cardiac problem, it's an EEG pattern, that there is gross chaos. What I mean by gross chaos is that normally we have a background rhythm, we have alpha, we have beta, depending on our eyes are open, eyes are closed. But here, like there is no fixed pattern, it is just chaos of abnormal electrical activity happening. This is one of the very characteristic manifestations that is seen in infantile spasms, which is also called as salam seizures. Salam seizure is the only Hindi word in medical literature. So at the moment, I don't want to write the word salam seizure because this examiner knows you will answer. So he will say the word West syndrome or infantile spasms are the terminology. In fact, like since I've discussed this subsequently also, instead of writing the word West syndrome, which is still easily identifiable, salam seizure still easily identifiable, I would just like to say that this is a EEG finding that can be seen in patients of infantile spasms. Now, when these patients will grow up, some of these patients could be having a neurocutaneous disorder. If you look at the back of this person, I have discussed neurocutaneous disorder separately, but you can notice this white hypomelanotic macules which are present in the back of the person. So this is presentation of ash leaf macules. That means we are talking about tuberous sclerosis. And then you can see a lesion just above the undergarment waist of the patient. This looks like if I zoom in, this is having an irregular consistency. Obviously some hypopigmentation is present, but the irregular appearance is also present here. So this irregular appearance, if you feel under the under the pulp of your finger, the feel will be as if you're feeling like an orange peel. Guys, obviously, last time you would have read orange peel consistency would be for Pude orange in breast cancer. But today I'm teaching you a orange peel consistency of a lesion on the trunk of an individual. That is what is called as a Sjagren's patch. Both of these manifestations that I've currently mentioned here before you, one I'll say again, this is a hypomelanotic macules. He may write the word hypomelanotic macules, he may write the word ash leaf macules. The combination of the two things that I mentioned, that is the EEG finding of gross chaotic pattern, Hips arrhythmia and ash leaf macules with Sjagren's patch, means that the patient is having a neurocutaneous disorder by the name of tuberous sclerosis. Tuberous sclerosis, if is present, then we will change our answer to this particular question as vigabatrin. But suppose if the only question mentioned was infantile spasm, Hips arrhythmia, and the question mentioned like what is the drug of choice for this condition, then this is very peculiar answer that you need to remember, that we will give ACTH. I mean, traditionally, like for any epilepsy based question, we have to answer anti-epileptic drugs, but this is the only scenario where you will be answering a hormonal injections being given for a patient. The learning point is if alone the EEG image or the theory is given, you will answer it as ACTH based on infantile spasm. But if it is associated with tuberous sclerosis, then you will change your answer to vigabatrin. In vigabatrin, IN word is there that again helps you infantile spasm to be remembered. More information will be provided as we progress in the discussion, but you can see that suddenly I accelerated from normal to gross abnormalities. We'll do a 15-second recap. Less than 3 hertz if written in a question with spike and slow wave, don't answer absence, it is Lennox-Gastaut. If it is 3 hertz spike and slow wave pattern, then it is absence seizure. Details of like how clinical presentation occurs will be explained to you. The answers would be ethosuximide, valproate, lamotrigine. Any of these three can be used. And for patients who are having infantile spasm, depending on presence or absence of tuberous sclerosis, the answers will vary. Now we talk about another question that came in FMG exam. Very simple. He said seizures are occurring in a patient for duration more than 5 minutes in a patient with GTCS, and he said, what is the first line management? Now, a lot of guys who read this question casually, they simply answered it as sodium valproate. Guys, this presentation is that of GCSE, that is generalized convulsive status epilepticus. In generalized convulsive status epilepticus, the seizures should be present for a duration more than how many minutes, that we will call it a generalized convulsive status epilepticus, then it is more than 5 minutes. And that is like pretty a serious thing to happen, because if your body is having that violent shaking with uprolling of eyeballs and the person is having these convulsions for more than 5 minutes, metabolic acidosis will set in, hyperthermia will happen, and like aspiration risk is dramatically increased, so person can die also. So the answer was not valproate, it was IV lorazepam that would be given to this patient. Now the same question was repeated in NEET PG, but it was modulated or given with a twist. The question said patient is having known case of GTCS. He was not taking medicines regularly. Usually, the problem why GCSE occurs is non-compliance. So this patient was not taking medicine regularly. He is having seizures for more than 5 minutes. Doctor has already given a first dose of lorazepam. The seizures are still not getting controlled. So what is the next step? इन FMG एग्जाम द क्वेश्चन वाज लाइक रिलेटिवली सिंपलर. वो बोला कि भाई क्या करोगे, भाई लोराजेपाम दोगे. यहाँ पे आंसर वेलपोरेट नहीं है क्योंकि भाई अभी उसको एक्टिव कन्वर्जन्स हो रहे हैं. बट इन नीट पीजी थोड़े ट्विस्ट मार दिया. What he said was patient has already had one episode and you are giving lorazepam, but it is like it did not work, right? So he said, what is the next step? What is the next step that you will be doing, or what is the next drug that you'll be using? Your answer will be that you will be repeating lorazepam. So the algorithm says that if the episode is not getting controlled with one shot, you can give a second shot to the patient if necessary. And the second thing that we do is we add dilantin. The brand name is dilantin, but you know that actual salt is phenytoin. It's a sodium channel blocker. It will stabilize the overactive neurons, because in epilepsy the neurons are firing more than normal. So to suppress the abnormal electrical activity in the brain, you need to give a sodium channel blocker, that is phenytoin. In American books, you might read the word fosphenytoin. It's relatively more fast acting. So phenytoin is usually diluted with normal saline. This is not important. This is just practical. I wanted to tell you that phenytoin is diluted with normal saline. It's given over 20 minutes. If phenytoin is not given, then we can give fosphenytoin, or we can give valproate, or we can give levetiracetam to the patient. So please be clear about the fact that it is not all three that are being used. It is any of the three that are being used. And if the question goes more deeper and he says the doctor has already given like 2 shots of benzodiazepine, one first line anti-epileptic drug, and still if the seizures are continuing, it means patient is having refractory status epilepticus. Now this is serious thing, right? I mean, this time the metabolic acidosis component, lactic acidosis component, hyperthermia, all of them are gonna be like pretty severe. So I need to be ready with like ventilatory support. I might have to intubate the patient, and what I can give at this moment is like, before I call the anesthesiologist and say, sir, I'm transferring the case to intensive care unit, मुझसे manage नहीं हो रहा है, the last shot that I can fire is I can either give IV midazolam drip, or I can give phenobarbital infusion, not phenobarbital, not phenobarbital. It is phenobarbital infusion that will be given to the patient. This is like a rapid acting drug which will basically suppress the epileptogenic foci. And if the case still continues to have seizures, then like it's pretty late now. Irreversible brain damage probably would have started occurring. So we need to give general anesthesia to the patient. We need to give GA to the patient using propofol. From part number 4, the anesthesia department will take over, but these are the steps in the algorithm. So I'll just move the slide and just say the algorithm again. Lorazepam first shot, lorazepam second shot, give dilantin, that is phenytoin infusion. Instead of phenytoin, you can give valproate also, lamotrigine, depending on the facility. Government hospital has phenytoin only. Now, if it's not improving, that means it's really a problem. That is refractory status epilepticus, implies 2 shots of benzodiazepine, 1 dilantin shot given, no improvement. You go to the next step, midazolam or pentobarbital infusion to be given, still not transferred to intensive care unit, where the person would be mechanically ventilated, because at this point of time, the damage to the brain will be pretty substantial. Update, according to like the latest guidelines for epilepsy, is that they mentioned the T1 time and T2 time for all this GCSE episodes for each variety of seizures. T1 time basically means time to treat. I mean, by 5 minutes, like he says, more than 5 minutes, it's like you have to be ballistic and aggressive in management. Just like Americans were ballistic towards Iran, right? When they decided to go on, they went full on, right? So we need to be super aggressive. And for T2, it says risk of neuronal injuries there. So the T2 value is just like a warning symptom. It's alerting the doctor, man, that you need to be like now sending the patient into intensive care unit, because the anesthesiologist would be the best person to handle this patient for mechanical ventilation. We need to go for rapid sequence intubation in this patient, but this is a medical emergency that we all need to learn. Now we talk about focal seizures. Now in GTCS, the whole body is shaking uncontrollably, eyes are rolling upwards, मुंह से झाग निकल रहा होता है, lips start turning blue. This is a IT professional. He says, doctor, listen to my words. He says, doctor, I was working on the laptop. Suddenly, his thumb started, he's calling it twitching, right? But it's actually a proper involuntary, powerful movement happening in the thumb. Then the involuntary movement started in the hand, then it started in the elbow, and then it started in the shoulder. And he's using his other hand to control it. You see, if you're having tremors can be controlled with muscle power, but you cannot control the violent shaking of the hand by your muscle power. So you're trying to control, he's trying to self-control these abnormal abnormal movements of the arms, which is occurring due to abnormal electrical activity in area 4 of the brain, that's in the motor area. So a lot of these patients will be saying to you that when I woke up in the morning, I wasn't feeling well. I said, what happened? He says, I was having an aura. Aura is like what you usually get with respect to patients who are having like migraine. So aura basically means like the patient might wake up by saying that in the visual field, some zigzag lines were present. He was not feeling relatively good, and he was saying I was having blurring of vision. Then the episode started, and when the episode started in the hand. Then it moved on to the elbow, then it moved on to the shoulder. At this moment, I can also say that if you're not seeing a patient with focal seizure in your life, then I would suggest you that after you're done with this video, just check out a video of mine on YouTube on the Preparator channel itself. It's an epilepsy. Just type my name, epilepsy. There's a video where I've shown different type of seizures, and you'll see a patient whose whole one hand is like he's using his other hand to control it, is the manifestation where the abnormal electrical activity starting from the distal part and is progressing proximally. This progression is what is usually referred in MCQs as either the word marching epilepsy or is also called as Jacksonian march. Let's do this again. The question will say, and nowadays all questions are descriptive. They don't write questions like focal seizure, drug of choices. The question will say, this is an IT professional. He was sitting comfortably working on his laptop, and suddenly he started having involuntary movements that started in the hands, then moved on to the elbow, then moved on to the shoulder, and the whole hand was shaking uncontrollably. And his friend is saying that even his face was twitching. You know, motor area of the brain, the face area and the arm area is very close. In the area 4 of the brain, when you study now, the face area and the arm area is very close. So they might be twitching of one corners of the face, and there's this involuntary movement. Is using his other hand to control it. So patient is conscious. You know, not every patient of focal seizure will become unconscious. Unlike in GTCS, where all patients are unconscious, in focal seizures, the patient can be having preserved consciousness, and the epilepsy is migrating right from the distal part to the proximal part. So I'm writing this once again for your practice. This presentation is what is called as marching epilepsy. The alternative name for this is called as Jacksonian march. And when this episode will end, then patient will say that I feel as if there is no power in this arm. He will say, I feel as if there is no power in the arm. That is TOTS paralysis. TOTS paralysis would mean that there would be a weakness in the affected arm. This weakness will be lasting for maybe like few minutes to hours. But I can say when this patient will come to you first time with weakness persisting in the arm for minutes to hours, you might think that he's having a transient ischemic attack or stroke as well, because in stroke also arm weakness would be occurring. But then he says, no, doctor, this happens every time. Every time I have an episode like this, I end up with weakness, and then there is a spontaneous improvement. So TOTS paralysis is a temporary weakness. It's a transient weakness that might be lasting in this patient for like few minutes to few hours, and then it will go away on its own. Now, some patients of focal seizures, when they come to you, they might say that before the episode started, like instead of saying that zigzag lines and aura description, he says like he's sniffing like this. And he's saying that, doctor, I could sniff like as if there is some rubber, when rubber burns, that's acrid smell. So he says, I could smell burning rubber. There's no burning rubber anywhere, but the guy can smell burning rubber. Or he says, I can smell some dead rat in the ward. Or he says that he can smell like something rotten fish. You get my point, right? Like everybody else is okay. Complex hallucinations are subjective sensations which are perceived by the patient. Everybody else is okay. He says, doctor, in your ward, no, I think there's some dead rat somewhere, but a ganda sa smell aa raha hai, or like some rotten fish. Or he's like sniffing and saying some acrid smell of burning plastic is coming or burning rubber is coming. So that is what I mean by the word complex hallucinations. And a lot of these patients might be doing like this. That is automatic chewing movements. Automatism basically means that patient might be doing like picking activity, like on the button of his shirt is doing like this, or he's like picking with his thumb and index finger, just like cotton lint. Like sometimes if cotton lint will come on your cloth, you'll just pick it up. So he's doing like this, picking up cotton lint. So automatism, as the basic as I said, it could be like lip smacking. Automatism could be picking movements that are occurring in this patient. So these are like all associations that can be present with respect to focal seizures, which can be given in a question. And then I will also mention one of the causes of focal seizures. Obviously, in India, it is usually neurocysticercosis only, which can contribute to both GTCS and focal. But in the MCQ, they have asked a cause which is having hippocampal sclerosis, that is fibrosis in the brain. So if you ever read the word MRI shows hippocampal sclerosis, then your clinical diagnosis in this case would be given as mesial temporal sclerosis, because hippocampus is located near the temporal lobe. The technical word would be mesial temporal sclerosis, and for this one surgery is required. Guys, otherwise, like if the question says what is the drug of choice for focal seizure, simple answer is carbamazepine. मेरे लिए तो सबसे आसान था. I could have just told you this fact that okay guys, cram up the fact that drug of choice for focal seizures is carbamazepine, but आजकल तो ऐसे क्वेश्चन आते ही नहीं है. I mean, if it comes, I'll be so happy, that I don't need to teach so many things and you guys would be like off pressure. So though in pharmacology, they just focus on the drugs per se, that is carbamazepine, I just want to bring to your attention that yeah, the medical management is carbamazepine only. But if he himself says the fact that the patient's MRI shows a hippocampal sclerosis, what is the diagnosis? Answer is medial temporal sclerosis. And this is one epilepsy for which surgery would be required. I'll write that points at the bottom of the slide. At the moment, let's do a recap of what we have learned. The MCQ focal seizure can begin with a person having either visual complaints, zigzag lines, aura, or it could be like, smell hallucinations, gustatory hallucinations, taste, metallic taste in the mouth, or like it could be olfactory hallucinations. That is what I mean by the word complex hallucinations with automatic behavior, and that focal manifestation of involuntary movement in the hand progressing from the distal to proximal part can be present. And obviously, like most patients will respond to carbamazepine, but not the guy with hippocampal sclerosis where we might be having to do surgery. Now, the next seizure that I'll describe before you is called as atonic seizure. In atonic seizure, unlike in GTCS where the whole body will become very tight and then will start shaking uncontrollably, in atonic seizure, there is a decrease in the tone. Because of generalized decrease in the tone, the person will fall down. There can be injuries also. So for atonic seizures, the questions will usually begin by saying the word drop attacks. The question will say drop attacks are, the answer is atonic seizure. And the drug of choice for management of atonic seizure should be answered as sodium valproate. Sodium valproate is a common answer for obviously GTCS, but it is used in atonic seizures also, and it is used in myoclonic seizures also. I'll repeat the statement. Focal seizures, it is carbamazepine, but if he talks about atonic seizures, then it is going to be valproate, and for myoclonic seizures also, it is sodium valproate only. That should be answered as the drug of choice. For carbamazepine, a miscellaneous point that I would like to add in the discussion is that it can contribute to SIADH, and because carbamazepine causes SIADH, it can cause a hyponatremia. So this is a pharmacology / medicine based question that came in the paper, that which of the following antiepileptic drugs can contribute to hyponatremia? Answer is carbamazepine. For sodium valproate, there are multiple side effects, but one of them is that it can cause damage to the liver. Because sodium valproate can cause pancreatitis, it can cause damage to the liver, so it must always be taken under medical supervision. And because it can cause liver damage, so the MCQ did not write the word liver damage, the MCQ said the word hyperammonemia. The remaining side effects I'll say verbally because you know them from pharmacology. It can damage the pancreas and it can contribute to alopecia, hair loss in a person also. But one of the dangerous ones is the risk of development of hyperammonemia. Now comes myoclonic seizures. Myoclonic seizures is the sudden jerky movement. Like earlier it was saying like, that whole hand was shaking in focal seizure. This is going to be like a jerky movement. I'll describe like this. Suppose you were studying, in the college or in the school, and suddenly somebody had placed a Diwali bomb in the toilet, and suddenly when that bomb will go off, loud noise, you focusing on studies, loud noise happens. So you're like suddenly started, like, India-Pakistan war, the drones came. So suddenly the drone explosion occurred. So people were startled. So I am having a patient. This guy is at 30, this guy is only 30 years of age. I mean, a very peculiar statement I'm saying. The guy is 30 years of age. He started having dementia. We get dementia at about 80 years of age with Alzheimer. 30-year-old guy with dementia, repeated episodes of startle myoclonus, psychomotor agitation, and EEG showing periodic spike wave pattern. This is very classical of a person. This man had consumed beef, which was of poor quality. If, like in India, there is no regulation on the kind of meat that you're eating. No, now the beef was poor quality, so the person consumed meat of a cattle that was infected. Remember, there's a condition you would have read by the name of mad cow disease. That mad cow disease is in medical circles called as bovine spongiform encephalopathy. The animal should be killed, the carcass should be disposed, but in India they're selling the meat of the dead animal in the open market, and you see the person has consumed that. So prion particles will go in the body of this patient and it will cause development of myoclonus in the person or myoclonic seizures in a patient. This peculiar presentation is called as variant Creutzfeldt-Jakob disease. This is a question which is hot favorite of INISET people. When you will be like reading about these questions in PVAQs, you'll notice this is given in the PVAQ section of INISET. That is prion disease, PRIU1. It's a proteinaceous infectious particle. It is one of the smallest infectious particle, I can say, and this does not have a DNA RNA. It only has a like a protein code. It keeps on replicating in the cytoplasm of the neurons, and it can contribute to this extreme manifestation of dementia, startle myoclonus in a person. If you ever read at 30 years of age, I've not written 30 because an MCQ to be 30, 40, whatever, but it will be young person. You don't get dementia. I mean, dementia is what you read with Alzheimer's disease at 80 years of age. And in Alzheimer, you don't have a myoclonus, you don't have psychomotor agitation, and there are no EEG findings like this. So, point to be remembered is young guy, whether he has mentioned consumption of poor quality meat or not, you should be able to solve the question on the combo of dementia with startle myoclonus. Next is a question on a teenager. He's 16 years of age. When he's getting ready for school in the morning, like when he's trying to drink milk, suddenly jerky movement of the hands, sudden jerky movement will cause spilling of milk on the dining table. Mother is literally slapping the child. Janbujke, you are spilling the milk. You want to be late for school. He's trying to open the toothpaste. Toothpaste has to be squeezed onto a toothbrush. So there's a jerky movement due to which the cap of the toothpaste is falling from his hand. So his mom is saying you deliberately keep on, falling objects. The objects keep on falling from his hand. So his mom is saying you are so careless, you are so clumsy, you are deliberately dropping objects. He spilled breakfast on his food because suppose you are eating. Yeah, suppose you are eating and there's a jerky movement of your hand, the food contents can spill over. So in this case, it would be like a mother who's saying that my teenager is having repeat clumsiness of his hand movements, and the clumsiness tends to increase with sleep deprivation. Then we did a EEG that showed a 4 to 6 hertz polyspike pattern. So another like EEG data being added to your vocabulary. This entire presentation is what is called as juvenile myoclonic epilepsy, and like for INISET people, this is what is called as Janz syndrome. This data, guys, that I'm describing, like myoclonic seizures part, is like more centric towards INISET and NEET PG. If you're an FMG aspirant, you need to know about the top three elements. The fourth one, you can go a little easy on it. But if you're a NEET PG or an INISET aspirant, you have to be giving more emphasis to the information that I'm saying now, that a teenager is having myoclonic seizures and is having EEG showing 4 to 6 hertz polyspike pattern. That's called as Janz syndrome. This is also called as juvenile myoclonic epilepsy. Obviously, for management of these patients, we will be using sodium valproate only, but like one more EEG pattern has been added to your vocabulary, that is 4 to 6 hertz polyspike pattern. I did not say spike and slow wave, I said polyspike pattern. Now we move down the age group. Earlier it was a 30-year-old man, then was a teenager, now is a 8-year-old boy. This 8-year-old boy started to have myoclonic seizures, that startle myoclonus, that is occurring with neurodegeneration, that is regression of milestones. And the hint in the question was IgG antibodies to measles virus are present. Then you will say that you're dealing with a case of SSPE, because measles ka jo late neurological complication hota hai, that is called as subacute sclerosing panencephalitis. This can also present with myoclonic seizures. The last one, I've already sensitized you to myoclonic seizures in an infant, and EEG shows hips rhythmia, is what is called as infantile spasms. This is also called as West syndrome, and alternative term for this is like Salam seizures as well. So there are 4 situations that I mentioned for like myoclonic seizures. I'll mention the age groups. I'll just move the slide. At 30 years of age, 40 years of age, with consumption of that beef, if it is given, otherwise statal myoclonus, you have to answer variant Creutzfeldt-Jakob disease, dementia will be there. If it is a teenager and the symptoms are worsening with sleep deprivation, juvenile myoclonic epilepsy. If IgG class of antibody to measles are given, then it is subacute sclerosing panencephalitis. And if he mentions a बच्चा, छोटा बच्चा, where like body बच्चे का ना आगे की तरफ झुक जाएगा, जैसे झुक के सलाम करते हैं ना, जैसे झुक के सलाम करते हैं, so the truncal muscles would be having a myoclonus here, and this is what is called the salam seizure, West syndrome. And these are like 4 situations for myoclonic seizures where we use like valproate, और आजकल उल्टा पूछ लेता है क्या नहीं यूज करते हैं, so oxcarbazepine is not used for these patients. Now we come to the commonest variety of seizures. This is the most common type, that is GTCS, that is generalized tonic-clonic seizures. Now we will talk about the most common type of seizures that we encounter, grand mal epilepsy or GTCS. The question will begin by describing a young teenager, or let's say a 20-year-old guy, not even teenager, 20-year-old guy. He was going to college today, so he told his mom, "Na thoda sir heavy, I'm not feeling well." So mom said, "Don't drive a bike, take a metro and go to college." So he said, "Okay." So he's going to metro, via metro to the college, and along with this, his one of his friends also, like he met on the metro, and two guys are like in the metro, they are like watching a video and they're laughing, or they're enjoying the watching couples laughter show. So his friend is telling you that, "Sir, suddenly, like we two guys were watching a video on a mobile phone, and suddenly he says, sir, like my friend gave out a loud cry." I said, "What loud cry?" He said, "Sir, he did like, ah, as if somebody is in a lot of pain." And then he fell on the floor of the metro coach. And he says, "I was shocked, sir. I don't know what happened. I thought like he fell by mistake or something." Now he says, "My friend fell from the seat onto the floor and his body became very tight." That is tonus. So first we will have a ictal cry, then after ictal cry we will have a tonus. The duration of the tonus may be usually under 30 seconds, but after this he says that the whole body of this boy started shaking uncontrollably. That is clonus. The clonus may again last for less than 30 seconds, but during this clonus stage, you will notice a couple of manifestations occurring in a patient. The whole body of the patient will be like shaking uncontrollably. So his friend is trying to hold him tight, but he will not be able to restrain the violent movements. At this moment, his friend is saying, sir, his eyes had rolled upwards. You will notice that जब किसी को, जिसको हम हिंदी में बोलते हैं मिर्गी का दौरा पड़ता है, so there is up rolling of the eyeballs of the patient. आंखें ऊपर चढ़ गई. साथ में there would be perioral cyanosis, because patient at this point of time, almost 30 seconds have passed by, has not been breathing. So oxygen saturation will begin to fall and the lips of the patient will turn blue. So his friend is saying, sir, his lips were so blue that I thought that he will die. मुंह से झाग निकलना शुरू हो गया. That is frothing at the corners of the mouth, because see, you and me keep on swallowing our saliva. Na? When we're talking, we tend to swallow our saliva, but in this patient, because the person will not be able to swallow his saliva, so you will notice that there would be a lot of frothing at the corners of the mouth of this patient. So his friend is really scared by the kind of events that are happening, and most of the time at end of about 1 minute or lesser, the event will stop by itself. First there will be tonus, then there would be clonus associated with uprolling of eyeballs, perioral cyanosis, frothing at the corners of the mouth. Don't try to hold the patient very tightly when the clonus stage is happening. That is a mistake that a lot of doctors and nurses do. They try to restrain the patient. Don't restrain the patient, sir. If you will restrain the patient, you will cause a shoulder dislocation. You can have like a subcutaneous hemorrhage or bruises developing in a patient. Like he says, first to no harm to any patient. So why to cause any soft tissue injury? Because this will stop by itself. What you need to do is secure an IV line and give him ibediazepam, lorazepam, whatever is available. And when the episode will end, that is, the patient will not immediately wake up. The person will still be unconscious. This guy will remain unconscious for maybe 15 minutes, 20 minutes, 30 minutes, maybe 1 hour, depends on case to case basis. And after like few hours, when he will wake up, he will be like in the hospital now. His friend requested a couple of people, please help me carry this guy out of the metro down to, near, like out of the metro station to, via an auto rickshaw. He brought him to the hospital. So he now says, sir, like this patient, he's now woken up after 2 hours. And when he woke up, he's like looking here and there. The last thing he remembers is he was with his friend at the metro station and he was watching a film on the mobile phone. And this guy had then become, he does not remember anything about unconsciousness and all the events that had transpired. So because the person was unconscious for this variable period of time and does not remember what happened, there is a post-ictal deficit. During the phase of post-ictal, I mean, why are we calling it deficit is because patient was unconscious. Why are we calling it a deficit is because the patient was unconscious for a variable period of time. At this point of time, when you would have examined the patient, you would have noticed a lot of khad sounds coming from the throat of the patient. That is rattling sounds from the throat of the patient because the secretions in the throat are cooling. You will notice that sometimes the person might even pass urine. The whole casualty will start stinking bad. There can be urinary or fecal incontinence. Patient का stool या potty निकल जाएगा when the patient is unconscious. This kind of a manifestation that I've currently described before you is what is called as GTCS, generalized tonic-clonic seizures, and this can happen usually again and again. What is the drug that would be used in this patient? Obviously, standard drug that is used is sodium valproate for even GTCS. The treatment is given for 2 years and then tapering is done. Never stop antiepileptic drugs on its own. This is again a question that treatment should be given for how many months minimum? That is at least for 24 months and then gradual tapering is done. And lamotrigine is one drug which can also be used in place of GTCS. I mean in place of valproate, but then lamotrigine has an advantage. It can be used in both GTCS as well as focal seizures. This again is a question that which antiepileptic drug has the advantage to be used in both GTCS and focal, because if history is not clear, here whole body is going to be shaking, whereas in focal seizures it is only like one arm and one side of the face that would be having uncontrollable movements. And now we come to the pediatric domain. Absence seizure is characterized by vacant staring spells, but most of the time MCQ will not ask you vacant staring. They will ask you this line: sudden brief loss of consciousness. Normally the thought process of anybody is that somebody will be unconscious, person will fall down, but in this condition there is no loss of postural control. The child is just like staring at you. There is no decrease of postural control. Child is unconscious, unresponsive, eyes are open. Child is unconscious, unresponsive, eyes are open, he's just looking at you. There is no loss of postural control. So that's the language that is given in the question. In earlier questions, no, like in FMJ exam they used to ask this vacant staring spells. अभी तो FMJ exam भी मुश्किल कर दिया, उसमें वो देता ही नहीं vacant staring spell. Like one of my previous exams was really a bad one, right? I mean इतना मुश्किल भी नहीं करना चाहिए. So I mean students were literally crying कि सर मतलब क्या vacant staring spell दिया ही नहीं, पूरा clinical domain बना दिया. A patient is having poor scholastic performance क्योंकि absence seizure है तो बच्चा जो है क्योंकि वो he becomes unconscious, unresponsive for a short duration. So teacher is like giving low grades to the child. So first he said problems at school, parent teacher meeting में जी बच्चे को डांट पड़ रही है, and like the parents are then noticing कि unresponsive हो जाता है, बोलता ही नहीं कुछ भी. There is like unconsciousness without loss of postural control. That was the word in the question, guys, that you need to remember. And the EEG finding if given नहीं दे रखा था. EEG फाइंडिंग मेरा स्टूडेंट कहता है कि सर EEG दे देता सर 3/second वाला तो मैं फिर भी कर लेता. ये दोनों जो स्टेटमेंट है, दीज आर द टू स्टेटमेंट्स विच वी रिलाई अवर आंसर ऑन. पर भाई मैं आपको ये बता रहा हूँ कि अगर वो क्वेश्चन का लेवल अप करेगा तो आप भी तो अपना लेवल अप करोगे ना, राइट? सो पॉइंट इज दैट इज ट्राइंग टू मेक इट टेक्निकल. ओवरवेल्म नहीं होना. डिजीज वही है, देखो बीमारी वही रहना है. इट इज जस्ट द फैक्ट दैट लाइक द एग्जामिनर मे नॉट गिव यू ट्रेडिशनल डेटा and then he will not ask what is the drug of choice for this condition. Obviously the drug of choice is ethosuximide for absence seizure. उस कंट्रोवर्सी में मत फंसना कि जी ethosuximide बोलेंगे, valproate बोलेंगे. बच्चों में होता है तो ethosuximide, older patients में होता है, adults में होता है तो valproate देते हैं. He is now asking you कौन से वाले drugs इसको worsen कर सकते हैं. So important point to be remembered is carbamazepine and phenytoin can worsen absence seizures in a patient, and it is ethosuximide that is used. Then another seizure he has asked is seizures that start with uncontrollable giggling and laughter. That is what is कि बच्चा जो है ना क्लास में बैठे बैठे हंसता रहता है, टीचर कह रही है बड़ा बदतमीज है, गिगलिंग करता रहता है, ये तो है ना, बेइज्जती लग रही है टीचर को. दैट इज जिलास्टिक सीजर्स कैन बी सीन कि जिसमें अनकंट्रोलेबल लाफ्टर होता है. द मोस्ट कॉमन टाइप ऑफ एपिलिप्सी इन चिल्ड्रन, ये आप लोग बताओ मुझे बिना नोट्स देखे, व्हाट इज द मोस्ट कॉमन टाइप ऑफ एपिलिप्सी इन चिल्ड्रन? द मोस्ट कॉमन टाइप ऑफ एपिलिप्सी इन चिल्ड्रन वुड बी आंसर्ड एज रोलैंडिक एपिलिप्सी. इट इज फोकल सीजर्स ओनली, बट ये फोकल सीजर्स क्योंकि बार बार होते हैं, फोकल सीजर्स बार बार होते हैं तो उसे रोलैंडिक एपिलिप्सी बोलते हैं. मोस्ट कॉमन टाइप ऑफ सीजर्स इन चिल्ड्रन बोलेगा तब बोलना दैट इज फेब्राइल सीजर, लेकिन एपिलिप्सी लिखा होगा तो फेब्राइल सीजर मत बोल देना. फेब्राइल सीजर जो होते हैं गाइस उसके लिए तो एपिलिप्सी वर्ड यूज नहीं होता ना, वहां पे तो प्रोवोक्ड है, प्रोवोक्ड बाय फीवर है. मैंने पहली लाइन क्या बोली थी? डेफिनेशन ऑफ वर्ड एपिलिप्सी इज 2 और मोर देन 2 एपिसोड्स ऑफ अनप्रोवोक्ड सीजर. तो फेब्राइल सीजर पे तो प्रोवोक्ड होता है. तो मोस्ट कॉमन टाइप ऑफ सीजर्स इन चिल्ड्रन, पहली बात तो कई लोग यहाँ पे भी गलती करते हैं, बोलते हैं जी बच्चे में कॉमन एब्सेंस सीजर होता है. नो, एडल्ट वाले में कोई गलती नहीं कि भाई एडल्ट में तो मोस्ट कॉमन टाइप that is seen with respect to adults, most common type that is seen with respect to GTCS, with respect to neurocystic psychosis is GTCS. But in a bacha, If he says the word epilepsy, then it's a common error that students make कि जल्दबाजी में यहाँ पे आंसर करते हैं फेब्राइल सीजर. भाई फेब्राइल सीजर तो फिर एपिलेप्सी की डेफिनेशन में आता ही नहीं है. एंड द कॉमनेस्ट टाइप ऑफ सीजर्स इन न्यूबॉर्न बेबीज इज सटल सीजर्स. मैंने देखो ओवरऑल टॉपिक को हैंडल करने की कोशिश करी. मैंने ऐसे नहीं करा कि यार मैं सिर्फ मेडिसिन वाला एडल्ट वाला डिटेलमेंट बताऊंगा, बच्चे वाला नहीं बताऊंगा, उसको वहां से पढ़ लेना. उससे क्या होता है कि एक ही टॉपिक को दो दो बार पढ़ना पड़ता है, कोई मतलब ही नहीं. वेन एवर यू रीडिंग अ टॉपिक, मैं एग्जाम्पल बोल रहा हूँ, सपोज आप पेप्टिक अल्सर डिजीज पढ़ रहे हो, तो आप यार उसको पहले मेडिसिन से पढ़ोगे, फिर आप सर्जरी से पढ़ोगे, फिर आप ओबीजीवाई से पढ़ो, मतलब फिर उसके बाद में उसको मतलब पैथो से पढ़ोगे, तो मतलब ही नहीं है यार उसका. राइट, आई मीन देयर सर्टेन टॉपिक्स विच आर हैविंग ओवरलैप बिटवीन वेरियस सब्जेक्ट्स. इन योर नोट्स देयर शुड बी इन वन पेज, पूरा कंसाइज हार्ड कोर इन्फॉर्मेशन होनी चाहिए भाई नोट्स पे. 10 पेज के नोट नहीं होते हैं. नोट्स आर ऑलवेज प्रिसाइज, देर ऑलवेज लाइक यू नो, मैंने बोला ना प्रेसिशन स्ट्राइक करनी है, तो प्रेसिशन स्ट्राइक जैसे यूएस ने करी, राइट. तो प्रेसिशन स्ट्राइक है इसकी, वो जैसे वो दिखाते हैं ना, आप देखे देखे होंगे ना, जो स्ट्राइक्स हैं ऊपर से कोई डैमेज नहीं लगता, बट देर ओनली 4 होल्स इन दैट बेस, ओनली 4 होल्स इन द बेस. पर वो कमांड सेंटर में चलेगी ना मिसाइलें. So I mean, you destroy the command center, then the whole system will fall apart. Everything in military runs on precision. Medical science runs on precision. Bodies runs on precision. So when you get those keywords right, you get the questions right. So coming back to the agenda, the commonest type of seizures in newborn babies subtle seizure, and the leading cause of this is birth asphyxia. Birth asphyxia को हम doctors बोलते हैं hypoxic ischemic encephalopathy. What we call it is HIE. Additional point which I want to bring to your attention is with respect to two drugs which are used as antiepileptic drugs. One of them is topiramate and the second one is zonisamide. Remember, topi and zoni, both of them are responsible for increasing the risk of kidney stones in a patient. The MCQ was which kidney stones, which of the following antiepileptic drugs increase nephrolithiasis risk? And a second question that was asked was which of the following antiepileptic drugs increase the risk of glaucoma? Usually the glaucoma that can be seen here is angle closure glaucoma, so will cause substantial amount of distress in a patient. So topi and zoni are two common inputs there. The additional aspect of topiramate is that it is the only antiepileptic drug that contributes to development of weight loss. All other by default will be causing weight gain, and therefore topiramate is also FDA approved for management of weight loss in those patients who are like having obesity and are having comorbidities and are not able to exercise enough. Then once again visiting these terminologies just to put rest to all the terms: West syndrome, infantile spasm, Salam seizure, they all basically mean the same, and the EEG finding has been shown to you that gross chaos, that is hips arrhythmia. We give either vigabatrin or ACTH injections for these patients, especially for association with tuberous sclerosis, vigabatrin. Jan syndrome is what I've explained to you, is juvenile myoclonic epilepsy, where 4 to 6 hertz pattern is seen and valproate is used. Then I spoke about Lennox-Gastaut syndrome. In Lennox-Gastaut syndrome, total of 3 varieties of seizures can be seen. GTCS, like in the morning, patient had a GTCS episode. In the afternoon, there would be decrease in the tone and person will fall down, drop attack. Even in GTCS, patient will fall down, but there the body will become stiff, tonus. In a tonic seizure, the tone will decrease, so drop attack, and later the person can be having atypical febrile seizures. So if in a single question is mentioned 3 different types of seizures, GTCS also, atonic also, and atypical febrile seizures. I'll explain what is atypical febrile seizure later. Then like 3 different type of seizures present in a single question, and saying less than 3 hertz spike and slope wave pattern is LGS, Lennox-Gastaut syndrome. The next one is pure Inisat based data, Dravet syndrome. This is related to voltage gated sodium channel, and this is being discussed because this is going to respond to, I mean, the question will mainly focus on this, that ketogenic diet and cannabidiol. I mean, cannabis is like what we read for, like, you know, patients who are having very severe cancer pain, that cannabis is used. But today I'm talking about cannabidiol being used for management of a seizure that is called as a seizure syndrome, that's called as Dravet syndrome, which is voltage gated sodium channel defect. So just remember this statement: ketogenic diet and cannabidiol is used for management of Dravet syndrome in a patient. Coming to febrile seizures, like he has asked what is the best drug for prophylaxis. For prophylaxis, guys, the answer is not rectal diazepam. You have to answer rectal diazepam for management of an acute episode. Like the mother is saying, I'm not a doctor, sir. How will I give it? So we'll say, we'll train you, ma'am. That is, we will train you how to give rectal diazepam. It is to be inserted. The catheter has to be inserted 2 centimeters from the anus of the child. Mother said, sir, no, sir, I cannot do this. No, putting something in the anus of child, mother may not be comfortable. So we can give intranasal. We can give intranasal midazolam to the patient also. So for episode management, either it is rectal diazepam or it is intranasal. But for prophylaxis, don't answer rectal or intranasal. For prophylaxis, check out whether it is intermittent or continuous given. For intermittent prophylaxis, like as long as the patient is having fever, we will be giving this drug oral clobazam. For continuous prophylaxis, it is valproate. And like minimum I expect you to remember is not to swap the answers for prevention versus acute episode. For intermittent prophylaxis, it is oral clobazam. Then how do you identify it is a febrile seizure? Because if a child is having fever, he could be having meningitis also. So if he mentions that the patient had a single episode that occurred in first 24 hours of the fever, if it is meningitis, the seizures occur on the second and third day and they're occurring multiple times. Here it would be a single episode lasting for less than 15 minutes and child will immediately wake up. Remember, GTCS patient was lying unconscious at the end of it for half hour, 1 hour, 2 hour. Here patient will open his eyes immediately after the end of an episode, and there would be a family history that is also given. Like mother is saying, when I was a child, no, even I used to have fever, not very high grade. Don't be under impression that febrile seizure will occur when fever will be 107, 106 degree Fahrenheit. No, 99 degree, 100 degree Fahrenheit, because of positive family history, increased excitability of neurons can trigger a febrile seizure, single episode within the first 24 hours. If it's gonna be more than one episode lasting for a longer duration, usually is a focal seizure. That is when we call it a atypical febrile seizure. And this atypical was the one that I described was associated with Lennox-Gastaut syndrome. Now focusing on a couple of updates like myoclonus. Negative myoclonus is asterixis. Negative myoclonus is asterixis. Asterixis is like flapping tremors that can be seen in patients of hepatic encephalopathy. But epileptic negative myoclonus is a new term that has been added in the update, where he says the person is saying, I'm very clumsy, I keep on dropping objects from hand, or he's like ऐसे ऐसे करता रहता है, head nodding, or like the knee briefly buckles, so he might tend to fall. So patient says that I am like a very clumsy person, I tend to fall or I keep on dropping objects. And the diagnosis in this particular condition is EEG will be done, but along with that EMG also shows like drop in the muscle tone. But this is not atonic seizure, this is different from atonic. The separate term that they've added is epileptic negative myoclonus, for which again valproate is used, thankfully the same drug. But I just wanted you to be aware of a new terminology that can be given, epileptic negative myoclonus. Otherwise, I can say that negative myoclonus, if you ever read the word, epileptic word nahi likha hua hai, only word written in the MCQ is negative myoclonus, then this is a different terminology being used for asterixis. Asterixis is what is called as flapping tremors. Ask your patient to extend his arms and then extend, like first extend arms and then extend the wrist, and you get that asterixis occurring in a patient. The reason why you get asterixis are manifold. I'll just write a couple of those causes here. Though this is discussed, like even asterixis I've discussed later, but anyway. Hepatic encephalopathy, ammonia intoxication, that is irritating the neurons. So asterixis or negative myoclonus can be seen with hepatic encephalopathy. I hope it is clear, guys, कि epileptic negative myoclonus and negative myoclonus are not the same. Epileptic implies the brain cause, but here it is toxin which is irritating the brain. So hepatic encephalopathy, ammonia intoxication. Second is uremic encephalopathy. So this time it is urea that is irritating the brain. Third is carbon dioxide narcosis. Carbon dioxide narcosis can be seen in COPD, exacerbation of COPD. I'm writing a short form here, AECB. AECB stands for acute exacerbation of chronic bronchitis. I've discussed this in RESPI also, this MCQ. The question was negative myoclonus / asterixis seen in all except, and the fourth option was Graves' disease. You guys tell me, in Graves' disease, do you get this asterixis or do you get that fine tremors of fingers? Exactly, fine tremors of finger. So a lot of guys, even if they were not aware of these things, no, they said, sir, we solved the question by exclusion. They were toxin data given, and then he said Graves' disease. Graves has fine tremors of the fingers, and not that flapping tremors of the fingers. So therefore, like easily differentiation can be done. And then for focal seizures, earlier you will notice that the words used to be like impaired awareness. Now he's said the word focal seizure with preserved consciousness. Like I was telling you, that IT guy was working on the laptop. He was conscious now, and he told me कि sir वो हाथ में ऐसे पहले jerky movement हुआ, फिर elbow पे हुआ, went to the shoulder. So that was like marching epilepsy. He described everything to me. But suppose he became unconscious and his colleague is telling me, then it is focal seizure with impaired consciousness in a patient. So it's just the fact that slight changes in terminology have been made. And then the T1 time for focal seizure is 10 minutes, like for like if the person is having status epilepticus later to focal seizure. Then the T1 time is 10 minutes. T1 is like by that time you have to start treatment. IV treatment has to be started in a patient. Lorazepam 2 shots as I explained to you. The point is for GCSE the cutoff was 5 minutes. This is again an update because normally the standard statement was that any seizure lasting more than 5 minutes is status epilepticus. But for GTCS, if seizure is more than 5 minutes, we call it GCSE. For focal seizure, if it's more than 10 minutes, then we will say that the person is having like a development of status epilepticus related to focal seizures. Now, after talking about this extensive topic, we'll focus on easier things, pyogenic meningitis, much more easier and simpler. I'll focus on 2 slides here, Gram stains. My students told me after the paper that the slide was showing as a blue two spots of like organisms present. So the movement you pick up these two organisms present together, we are talking about Diplococcus, and the Diplococcus is going to be pneumococcus, which is one of the leading causes of bacterial meningitis. In the second one, my student said that, sir, the bacteria were present in the security system. Like you can see, these are the cells, these are the security system. And then inside some of the security system, inside some of the security systems, we can be seeing these bacteria. Some are bacteria obviously present outside also. Like if I put markings here, some of the bacteria present outside, but some are present inside the security system also. So the point that I'm trying to make here is that I'm dealing with gram-negative bacteria. I'll write this once again. This is what I'm saying. This time the blue spots which are present. So I'm saying I'm dealing with gram-positive organisms. And second time, I am dealing with gram-negative organisms because they are reddish in color. Most of them are like extra. Some can be found inside the cytoplasm, like in the security system also. So the point is, if it is gram-negative, then it becomes Neisseria meningitidis. And if it is gram-positive, it is gonna be pneumococcus responsible. So obviously, like you are aware that meningitis is caused by either Streptococcus pneumoniae or by Neisseria meningitidis. But how he asked in the paper was that he asked it in the form of a gram stain representation. He said like he first described the triad of meningitis. The triad was patient came with complaints of fever, headache, nuchal rigidity, and the doctor has done a guarded lumbar puncture and then is planning to start empirical antibiotic treatment. So he said guarded lumbar puncture was performed, the CSF was sent to the microbiology department for a gram staining, and the image of the gram stain is shown. Comment on what is the organism that is present. So for point number A, and for the image number B, the answers will vary. For point number A, because it is gram-positive, blue diplococci present, my answer would be given as pneumococcus. This is overall the most common cause of lobar pneumonia and is also the #1 cause of bacterial meningitis. Yes, guys, the slide that is shown as B is not the most common cause of bacterial meningitis, though the impression that comes is that Neisseria meningitidis is overall the most common cause. It is not. It is pneumococcus, the #1 cause. The students then say, sir, I have read an MCQ where answer was Neisseria meningitidis. So what is that MCQ where answer will be Neisseria meningitidis will be either when the slide is shown like this, or there's a clinical question. The clinical question is showing rash. A clinical question is showing rash. So if I'm saying, if this petechial rash is given, if in the question gram stain is given, piece of cake. Blue versus the pinkish or reddish bacteria, gram-positive, gram-negative differentiation, you know. But in a clinical based question, if petechial rash is given, then the answer would be given as he may not write the word petechial rash, he may just write the word petechiae, he might write the word purpuras, because bleeding is associated because this bacteria causes DIC, then the answer is Neisseria meningitidis. How I have arrived at the diagnosis of Neisseria meningitidis is for 2 separate questions. In one, gram stain image was given. In the second one, it was that clinical finding of petechial rash and purpura was given. Now, what is the most common cause of neonate with bulging anterior fontanelle and vacant stare? I mean, most common cause of bacterial meningitis in a newborn baby. Bulging anterior fontanelle means raised ICP. So the organism in this particular case, in India, usually will be E. coli. Like if he mentions from the Indian perspective, then because of the hygiene issues being a problem, it is E. coli. But on a global basis, the organism will be answered by you as group B streptococcus. Yes, guys, on a global basis, the answer is slightly different. This is one of the common bacteria that is present in the female genital tract. The alternative name for this bacteria is Streptococcus agalactiae. So here in this particular slide, all I will do is make you revise your microbiology. That is Streptococcus agalactiae, alternative name is group B Streptococcus. This is on global basis. If you mention specifically for India, then the answer is E. coli. And in some apps, the answer may be given as Klebsiella also. It's okay, sir, gram-negative organism. Now, so it can be E. coli or Klebsiella. We really can't predict, but this is, I would say, most accurate answer. Now for age group between 3 months to 55 years, this is the most important data for this particular slide. Huge age group. After 3 months of age and up to 55 years of age, the number one bacteria that is responsible for causing pyogenic meningitis is the gram-positive diplococci that I had shown to you initially, that is pneumococcus. Suggested read is from your microbiology, do read about the characteristics of pneumococcus. Like we have special types of colonies which are present here, no? That's Draxman colonies and all those things. So that data from microbiology can be incorporated in the question also. The number one cause is pneumococcus. I've already explained to you that if he says pyogenic meningitis in an adult with purpuric rash and distributive shock or petechiae, that is given because DIC will be coming in this patient, septic shock, distributive shock because sepsis is occurring, it is septic shock that is occurring, then the answer would be given as Neisseria meningitidis. This organism can contribute to even development of bleeding in the adrenal gland because Neisseria meningitidis can cause development of DIC, that is adrenal hemorrhage. If the bleeding will occur in the first layer of the gland, then aldosterone production will crash. If the bleeding will occur in the second layer of the gland, the cortisol production will crash. So the blood pressure as well as the blood sugar of the patient will crash, and therefore this manifestation can also be written as Addisonian crisis. In endocrine section, I have explained to you that a person can be having Addisonian crisis due to sudden stoppage of steroids. But today, I'm teaching you Addisonian crisis can occur. Meaning, what do you mean by Addisonian crisis? Both things will crash. Blood pressure, if in any question BP is crashing, BP crashes in so many conditions. Obstructive shock, distributive shock, hypovolemic shock. I mean, BP crashes in so many conditions, but crashing of blood pressure with like hypoglycemia, that is exclusively seen with Neisseria meningitidis, and that is why the word that's used to describe this manifestation is called as Waterhouse-Fridson syndrome. I'll just jot down the name here on the side. This is a revision of your microbiological details also. I'm very sure madam has described this. Waterhouse-Fridson syndrome is seen with Neisseria meningitidis. What is the presentation called as? All the details that are given for this particular description, where a person came to my hospital. He was having features of meningitis. How will meningitis be given? Fever, headache, nuchal rigidity. Then he said there is a rash, and then the BP of the patient was crashing. Blood sugar was crashing. I'll say this again. Fever, headache, and nuchal rigidity are the basic starting lines of any question on pyogenic meningitis. Then he will say lumbar puncture was shown, that was showing presence of guarded lumbar puncture was done. It was showing findings of neutrophils present in the CSF of the patient. Then the BP was beginning to crash. Blood sugar was beginning to crash. There was a rash on the extremities of the patient. So all this is called as Waterhouse-Fridson syndrome. Obviously, you will give antibiotics, but here hydrocortisone will also be required now because Addisonian crisis is occurring in a patient. So that's why he says perform guarded lumbar puncture and start empirical antibiotics within. In all cases of meningitis, by default, in all cases of meningitis, you should be starting treatment within. Answer is 60 minutes of admission. You have to start within 60 minutes of admission. Like if the patient is admitted right now, then within 60 minutes of admission, I should be starting the patient on antibiotics. Lumbar puncture can be delayed by more than 1 hour. But antibiotics cannot be delayed. If you think meningitis is some chota mota illness, no guys, meningitis by these nasty bacteria can be having as much as 30% mortality. I want you to appreciate the fact meningitis without antibiotics can cause as much as a 30% mortality. So he says you may do lumbar puncture later because you were busy attending to different cases and you are the alone resident on duty. But the first shot of empirical antibiotics should be started within 60 minutes of admission. And what is that antibiotics that would be started? So there are two important antibiotics which are to be started here. Let's mention the names here. That is, one is ceftriaxone because it has a very high penetration into the CSF. It's a third generation cephalosporin. And the second antibiotic that we add is vancomycin. In some MCQs, instead of writing the word ceftriaxone, he might write the word cefexime also. I'm perfectly okay with it, cefexime or like ceftriaxone, but I have to give it intravenously for better penetration, and I will be giving vancomycin. On this, the query I get from students is, sir, why vancomycin? There is no Staph aureus here. You are saying that it is pneumococcus Neisseria meningitis. So vancomycin क्यों? So vancomycin is given because nowadays we're getting resistance to ceftriaxone. Imagine, man, due to indiscriminate antibiotic usage by these quacks in the villages, na, we are having resistance to ceftriaxone and cefixime at the moment, and vancomycin is not being given for coverage for any Staph aureus. There is no Staph aureus here. It is rather being given because I want to give coverage. Because I know that sometimes patient can be having ceftriaxone resistance. In the first 48 hours, two antibiotics would be given. After 48 hours, culture report will come. When the culture report will come, then you can discontinue. When the culture report will come, then you can discontinue one of the antibiotics depending on whatever is the culture sensitivity report. But empirical antibiotics means two antibiotics should be given. The rationale is first perform guarded lumbar puncture and then start empirical antibiotic. The logic is first we do guarded lumbar puncture, we take some CSF, examine it under a microscope in the ward itself, you can see the neutrophils, and then you can start empirical antibiotic in the patient. But you have to add coverage for a bacteria by the name of Listeria monocytogenes. If he himself says the word immunocompromised patient, or he says alcoholic, or he says heart transplant patient, kidney transplantation, liver, कोई सा भी ऐसा नहीं है कि सिर्फ हार्ट का ही है. Heart transplantation, liver transplantation, kidney transplantation, all patients are on immunosuppressive. All patients are on immunosuppressive treatment, and therefore another bacteria can be causing a problem by the name of monocytogenes. I'll just write the names once again. The name is Listeria. The same bacteria जिसमें tumbling motility होता है. This bacteria is having tumbling motility. The name is Listeria monocytogenes. This is a organism that is for which additional coverage is required. Then what antibiotic should be added? I mean, what antibiotic should be added for Listeria monocytogenes? Then this bacteria is not sensitive to third generation cephalosporin. Shocking, guys. This bacteria, Listeria monocytogenes, is not sensitive to ceftriaxone and vancomycin. Rather, surprisingly, it is sensitive to ampicillin. So you will get lot of questions where three antibiotics have to be answered. He will mention that the patient is an alcoholic. He presented with fever, headache, and nuchal rigidity. Or instead of saying alcoholic, he may say patient underwent some kidney transplantation, heart transplantation, whatever, and today is having features of meningitis. Then what is the antibiotic empirical regimen that you'll be giving, considering that his immunity is lesser and we need to give coverage for Listeria monocytogenes apart from the ones in the black superiorly? न्यूमोकोकस भी हो सकता है, नाइसीरिया मेनिंजाइटिस भी हो सकता है, लिस्टीरिया मोनोसाइटोजीन्स भी हो सकता है. By looking at the face of the patient, I can't find out which bacteria is responsible. By looking at the face, I cannot pick up which bacteria is responsible. So in the first 72 hours before the culture report will come, I will give 3 antibiotics to the patient. 3 antibiotics, cefixime or ceftriaxone, that is 1, vancomycin is 2, and ampicillin is 3. Then as far as mass chemoprophylaxis for Neisseria meningitis is concerned, because Neisseria meningitis droplet से फैलता है, so because it spreads by droplets, so for mass chemoprophylaxis in a patient, the antibiotic that would be given is ciprofloxacin. I'll just write it here. We need to give fluoroquinolone, ciprofloxacin for like mass like chemoprophylaxis if it is required. And the last statement is what is, even the pathologist would have said it, that recurrent meningitis in adults with meningococcus is due to terminal component deficiency. This terminal component is C5 to C9 deficiency. So this slide is like full of mainly like what is the antibiotic approaches that you'll be using for a patient. I'll just make you practice the data once again. I'll just remove the slide. अगर बच्चा बोलेगा न्यूबॉर्न बेबी तो आप बोलना ई कोलाई या इट कैन बी ग्रुप बी स्ट्रेप्टोकोकस, ईदर ऑफ द टू, सो कल्चर पे डिसाइड हो जाएगा. बट इफ इट इज एनी चाइल्ड ओल्डर देन 3 months एंड एडल्ट्स अप टू 55 years of age, देन यू हैव टू थिंक इन टर्म्स ऑफ व्हाट बैक्टीरिया. नाइसीरिया मेनिंजाइटिस, न्यूमोकोकस. अगर एक बोलता है तो बोलना न्यूमोकोकस इज मोस्ट कॉमन कॉज, अदरवाइज ही विल गिव यू द स्लाइड. Or he will himself say tumbling motility has been detected after 72 hours. But before I come to know by 72 hours what is the bacteria, I will have to give coverage for everything. No? So I'll give coverage for pneumococcus, I'll give coverage for Neisseria meningitis. I mean, both will respond to the combo of ceftriaxone with vancomycin. And the third antibiotic I will add here is ampicillin. और ये नहीं है कि हार्ट ट्रांसप्लांट लिखा तो उसी में होता है. Anybody with immunocompromised status, you will have to do this approach. Then comes an important data. पहले लंबर पंक्चर करेंगे या पहले न्यूरो इमेजिंग करेंगे? यू नो द थॉट प्रोसेस ऑफ आर्स इज कि यार मेनिंजाइटिस का केस है तो सीधा लंबर पंक्चर कर दो. कहता है नहीं, Lumbar puncture is contraindicated in patients of raised ICP. Lumbar puncture is contraindicated in patients of raised ICP. अगर हमने raised ICP में lumbar puncture किया, there is always a big time risk of brain herniation. This happened in one of FMG students who was studying in Kazakhstan. I think it was Almaty only, or one city near Almaty, where the student, he was having this headache. I'll discuss his case also with you, the later part. This boy, he was alone, foreign country or विदेश है, भाषा आती नहीं. He went to that local center, and I'm not blaming, doctors से गलती कहीं पे भी हो सकती है, but then it is very very unfortunate. This boy, he went there and they said we will do lumbar puncture because they suspected a CNS event. Logical, but they should have done a CT scan पहले, then planned it. So when they did a lumbar puncture, probably some resident would have done it who's new to the job. So एकदम से CSF का gush हुआ. So that caused his brainstem to get displaced inferiorly, and he immediately went into respiratory arrest, and the poor boy had to be put on a ventilator. Then you all know, everybody on social media was posting, and the Indian government finally, thankfully, did take note. पहले तो सुनते ही नहीं थे, तो they flew him back to India, but he died at SMS Jaipur later, no, because एक बार यार respiratory arrest हो जाए तो prognosis तो becomes very very bad. So very sad, but the learning point for all of us doctors at the moment is that never rush into doing a lumbar puncture in a case of meningitis. First give mannitol. अगर आपको दिख रहा है कि रेज आईसीपी है, कैसे पता चलेगा? फंडस करते हैं ना, फंडस एग्जामिनेशन में पैप्लोडीमा आता है, पैप्लोडीमा आता है. तो अगर फंडस एग्जामिनेशन, उसका शायद किया ही नहीं उन्होंने फंडस एग्जामिनेशन, सीधे लंबर पंक्चर कर दिया, तो दो मेरी टोन एक्यूजिंग लगेगी कि यार आप दूसरे विदेश के डॉक्टरों को ब्लेम कर रहे हो यार, पर बनता तो अपना था ना, है ना. तो मतलब थोड़ा सा बायस तो आ जाता ना यार, कि मतलब वी वुड एक्सपेक्ट बेस्ट मेडिकल केयर. सोवियत यूनियन में देखेंगे, फॉर्मर जो सोवियत यूनियन है, there I can say that spine surgery is very good because they have been winning in gymnastics, so they come across a lot of orthopedic trauma, so they're very good with spine surgery, neurosurgery. But neuromedicine, thoda sa, what I feel is a little dicey. So anyway, coming back to the agenda, never rush into lumbar puncture, guys. Always do neuroimaging first if any one of the following is present. What is present? Pin fan. Pin fan में क्या क्या याद करना है? Let's do it. Pin first. Papilledema. Eyes are the eyes are the entrance to the brain. You can see the optic disc. If the optic disc is swollen, that means that you are not supposed to do lumbar puncture. There will be gush of CSF, brainstem herniation will occur. The person will go into respiratory arrest. Immunocompromised state. So you will notice आगे जितने AIDS patients होंगे उनमें first I will be doing neuroimaging to check for evidence of raised ICP. Then I'll be doing a lumbar puncture. Then if there is seizures, new onset seizures. So PIN is papilledema, immunocompromised state, not a previous old epileptic. I'm saying new onset seizures because of CNS infection. So there would be some cerebral edema component. I would like to treat that cerebral edema first before I do lumbar puncture. Papilledema, immunocompromised state, new onset seizures. Then there can be focal deficit. Focal deficit like one arm weakness, one leg weakness. So we need to know whether why stroke manifestations are occurring. Altered sensorium. Then again, don't do lumbar puncture. And if person is having a known CNS lesion, if it's a known case of brain tumor, and I do lumbar puncture, already the pressure in the brain is high. It will accentuate the brain herniation. The patient will die. As far as the mnemonic is concerned, आप फैन वाले कंपोनेंट चाहे ना भी याद रखो चल जाएगा, लेकिन जो ऊपर वाले हो तो मस्ट है. I mean, those are like very characteristic words that will be added in the question. You'll say fever, headache, nuchal rigidity. On fundus, patient shows papilledema. What is the first investigation? Your answer is CT scan. He will say AIDS positive patient, fever, headache, nuchal rigidity, fundus shows papilledema, two risk factors, papilledema also there, and HIV positive patient. I will again do a CT scan. He says fever, headache, nuchal rigidity, patient is having fundus showing a papilledema, and patient also had 1 or 2 episodes of seizure, is not an epileptic. Meningitis is causing such of severe brain infection that seizures are occurring. That means there must be some cerebral edema. I will first do a CT scan in the patient. PIN is a must know, papilledema, immunocompromised, new onset seizures. Others are like focal deficit, altered sensorium, and then neoplasm present in a patient. The 6-word mnemonics, 5-word mnemonics, short mnemonics होने चाहिए. Long तो कभी वर्कआउट ही नहीं होते हैं, और मेरे हिसाब से तो 3 words होने चाहिए. Most mnemonics that I discussed now are like very short, because ultimately you can't remember everything. So I'll say it once again, guys. What you should remember is lumbar puncture is contraindicated in papilledema. Immunocompromised state, new onset focal seizures, focal neurological deficit, right? Oh, मैंने बढ़ा दिया, right? Another additional point I made you remember, focal neurological deficit in a patient. The total of 6 to be remembered, including altered sensorium and neoplasm, but the PIN is like a must know. In all questions of meningitis, don't blindly answer as guarded lumbar puncture. check out whether these words are given in the question or not. If pen fan is not given, then your answer is guarded lumbar puncture. If pen fan is given, what will you answer? You will answer CT scan. You will say, I can do MRI also. Yeah, CT fast hota na. So neuroimaging is to be first done if any one of these is present, is the message that I want to give to you. And now we will focus after bacterial meningitis on viral encephalitis. In viral encephalitis, the question will always begin by describing a person. He is from a village, he is from a peripheral area. Village का भी क्यों reason दे रहा है वो भी बताता हूँ. They would be like fever. Then he will say the person was having headache. So you will think that he is talking about meningitis, but now there would be no mention given of nuchal rigidity. He will say the patient had fever for only 1 or 2 days. सिर्फ एक या दो दिन का तेज बुखार था. It was like high grade fever for 1 or 2 days. And then the person he started acting very bizarre. Family members are saying he was not waking up. Like normally this guy is very active. He goes to work every single day. He says my son was not getting up. And now he's forget about getting up. He's not even opening his eyes. His mother is shaking his son, 30 years of age, in front of you, sir. See, he's not opening his eyes. And even if he's opening his eyes, he's just staring at his mom as if he does not recognize her. Altered sensorium in fever of 1 or 2 days, guys. Viral encephalitis in Hindi is called as dimagi bukhar. Dimag is brain fever. This brain fever can be so lethal that it can result in development of complete loss of memory, because the organism that I'll discuss before you has predilection for the temporal lobe. This MCQ himself will say MRI shows temporal lobe inflammation. If temporal lobe is damaged, then temporal lobe is the area where memory is stored. In temporal lobe, we have hippocampus. This infection that I'm going to describe before you is so dangerous that this person will lose his memory forever, even if you save him. He may not remember what is his name, what is his personal mobile phone number. Some common details we remember all of our life, our birth date, our mobile phone number, home address, father's name, mother's name, like routine details. The guy will forget everything, just like in Alzheimer's disease. Then the examiner will also give hint RBCs in the CSF of the patient. The EEG finding that is given here is called as PLED, that is periodic, because it is present in the temporal lobe, so lateralized. Temporal lobe is laterally located. So periodic lateralized epileptiform discharge. Do not mix it with periodic sharp wave complexes that are described for prion disease in patients of variant Creutzfeldt-Jakob disease. वहाँ पे भी मैंने एक term बोली थी जो शायद आपने उस टाइम पे मिस करी होगी, but I'll move up the slide. When I was describing that mad cow disease wala patient who had consumed that poor quality beef, then the person was having variant Creutzfeldt-Jakob disease. There the word was periodic spike wave pattern on the EEG of the patient. So I'm gradually building up your data for electroencephalography. And what you have seen in this discussion at this moment is the word is different. This is periodic lateralized epileptiform discharge. So I will be starting empirical treatment with acyclovir. By this time you will say, sir, आप organism तो बताए नहीं. तो भाई, I think you would have guessed the answer by this point of time. What is the organism responsible which causes dimagi bukhar? Then your answer is herpes simplex. Herpes simplex is also two types, herpes simplex 1 and 2. 2 causes sexually transmitted disorder. So what I'm teaching at the moment is herpes simplex 1 encephalitis. Guys, this is such a dangerous infection that the person can lose his memory. So though the investigational choice for this condition is a CSF PCR for herpes simplex virus 1, but I will not wait for the PCR report to come. भाई वो report आने में 2 दिन 3 दिन लग जाएंगे. हो सकता है my city may not have facility. I might send the sample to Bangalore, may send the sample to Hyderabad, and then the report will come. So I will start treatment with acyclovir intravenously ASAP as early as possible, so as to prevent the damage caused to the temporal lobe by brain fever. How will you pick up herpes simplex encephalitis in the MCQ? The question will mention MRI shows temporal lobe inflammation. Lumbar puncture shows RBCs in the CSF. Normally, to lumbar puncture we read about lymphocytes, we read about neutrophils. Here is talking about bloody CSF. Bloody CSF will come in the discussion again for subarachnoid hemorrhage, but this is not the case of subarachnoid hemorrhage that I'm talking about. So इनमें से कोई भी hint दिया हो सकता है. It can be either MRI shows temporal lobe inflammation, lumbar puncture shows RBCs in the CSF, EEG shows periodic lateralized epileptiform discharge. If any one of these points are given, or if they're not given, फिर भी fever, headache, altered sensorium within 1 or 2 days, first cause, even if this information is not given, is herpes simplex encephalitis. But if he mentions specifically state of Uttar Pradesh, he mentions the district, right? That is Yogi Ji's district, Gorakhpur, then your answer will change. Obviously, because of the efforts of the UP government, no, now we have stopped having cases of these. But government was very aggressive regarding Japanese bee encephalitis vaccination. Please read about the live and the killed vaccines for Japanese bee encephalitis. It is transmitted via Culex mosquito. It is transmitted via the Nuisians mosquito, which breeds in dirty water. Like after rains, no, dirty water accumulates in the slum area, and that is where the mosquitoes can breed. So the Dimagi Bukhar can be by Japanese bee encephalitis, for which no treatment is available. Acyclovir does not work here. So your answer would be given as Japanese bee encephalitis. If he says UP, and then if he changes the question and says Kerala, or if he says West Bengal, if he mentions areas like Siliguri, Siliguri, or like some cities away from Kolkata, West Bengal, and then Kerala, like Kozhikode district. So Kerala, if it is mentioned, then the Kerala outbreak will obviously be Nipah virus. For this Nipah virus thing in the exam, he described a person having fever, headache, altered sensorium. He mentioned Kerala, and he gave this life cycle also. He said, what is the cause? Obviously, you can see a bat, you can see pigs and human being, and you can see date palm sap, you can see the palm tree, no? Date palm sap which is used, it is contaminated with the urine and the fecal matter of the bats. So therefore, the virus that we're talking about is called as Nipah virus, which again has almost a case fatality ratio. Nipah virus, guys, has a case fatality ratio of almost huge 40 to 75%. It causes death due to development of encephalitis in a patient. Here, Nipah virus is spread via, like how is Nipah virus spread? Then it is spread via bats. The technical name for the bat is, Pteropus. It is spread via, what is the exact methodology by which this infection is transmitted? Then it is spread via consumption of fruits, which are contaminated with the saliva and the fecal matter and the urine of the fruit bat. I said consumption of fruits which are contaminated with the saliva, or instead of saliva, it could be fecal droppings. Like the bat sat on the fruit, it ate a part of the fruit, then it defecated on the fruit also, and then it left, and then the full fruit on the ground, child ate it. And he ended up with Nipah virus infection, which causes death due to encephalitis. So consumption of fruits contaminated saliva or fecal droppings of the fruit bat. And what is the technical name of the fruit bat? That is what the examiner wanted to hear. This is what we will say as Pteropus. It is the fecal droppings of the Pteropus which would be responsible. So Kerala outbreak is what I've currently explained to you with respect to Nipah virus. If he does not say Kerala, West Bengal says UP, then it is Japanese bee. And overall, the number one cause, no state given in a question, should be answered as herpes simplex encephalitis, which is called as Dimagi Bukhar. Now we will study regarding CSF findings. If you are an FMG student, this slide is the must know slide. In whole of CNS में बोलूँगा, medicine के perspective से and FMG exam के perspective से, this is the main slide that you need to remember. बाकी मतलब मैं बोलूँ बाकी भी चीज़ें important हैं, but this is one of the most oft asked questions that they'll give you a lumbar puncture report. बहुत सिंपल है, बहुत सिंपल स्ट्रेट फॉरवर्ड है. नीट पीजी वालों के लिए तो बाय डिफॉल्ट है कि भाई तुम्हारे लिए तुम्हें तो आना ही आना है, बट देन दिस इज लाइक अल्ट्रा सिंपल डेटा. सो लेट्स वर्क इट आउट. नॉर्मल पर्सन्स CSF. Normal person's CSF will also be having, like you guys tell me, do you have cells in the CSF of a normal person? The answer is yes. Now we need security system everywhere na. So the normal number of cells in the CSF of a person would be 0 to 4 lymphocytes per cubic millimeter. You see, if at airport we need security, if anywhere else in the body we need security, then in the CSF area we obviously need security. So I'll just write this again. We do have cells in the CSF of a normal person. How much are the cells present? Your answer would be 0 to 5 lymphocytes per cubic millimeter. The sugar of the CSF of yours and mine at the moment is 2/3 of the blood sugar. Let us assume that if your blood sugar at the moment is 100, then your CSF sugar would be something like 66, so 0.6. Protein values will be 15 to 45 milligram percent. This is like normal values that I'm describing. All the units here are either in milligram per deciliter or like per cubic millimeter. The report is always given like for sugar and protein it will be in milligram, and for cells obviously the absolute number would be present, but everything in the denominator is per cubic millimeter. What is the normal opening pressure in the brain? Ventricles में हमारा pressure कितना होता है? तो answer is 10 to 20 millimeters of mercury. What is definition of raised ICP? Pressure more than 20, and sometimes the units may change. He may call it 50 to 180. not centimeter of water, but millimeters of water. So I taught you two definitions of raised ICP, that is pressure in the brain more than 20 millimeter of mercury or more than 180 millimeters of water is raised ICP, and the color in this case would be clear. Now, if it is acute bacterial meningitis in a patient, do a ink change if you're noting it with me. In acute bacterial meningitis, there would be neutrophils present. So you will be having almost 1000 or more than 1000 polymorphonuclear cells, that is neutrophils present per cubic millimeter. Okay, I'll not write cubic millimeter, that just make the slide dirty. It can be 1000, it can be 5000, it can be 10,000, it can be 500 also, but usually it's more than 1000 neutrophils because there is bacteria present here and the bacteria will consume the sugar. So the value of sugar here will be always less than 0.6. They'll give you random blood sugar in the question. They'll give you CSF sugar, divide the two, value should be less than 0.6. Proteins will be elevated because antibodies will be produced. In this case, any infection in the body, there has to be antibodies present, and the pressure in the brain will also rise because there's the inhibition of the reabsorption of the CSF, because जो pus होता है, that is like thick, so that pus will block the arachnoid granulations. So it is the inhibition of the absorption of the CSF. It is the inhibition of the absorption of the cerebrospinal fluid, which is responsible for increase in the pressure, and the color will be turbid or cloudy, but don't use color for diagnosis. It's always going to be like the inhibition of the absorption of the CSF. Then can be tubercular meningitis. In tubercular meningitis, again do a ink change. This time it can be like between 100 to maybe going up to 1000. Absolute numbers don't matter. What matters is what is the type of cells present here. This would be a chronic infection. Because of chronic infection, it would be lymphocytes that would be present. The sugar in this case will also begin to reduce because there is an infection present. The bacteria will consume the sugar, the security system will consume the sugar, so the sugar will drop. The proteins in this case will be elevated, so much elevated that it will usually be in grams. So if they give you a question in the paper where like the CSF present is like more than 1 gram per cubic millimeter, you have to think in terms of TB meningitis. The amount of protein in the CSF of this condition can be so much that if you keep the CSF in a test tube, then the protein will begin to clot in the test tube like a basketball net. Like at the moment you can see that the protein is literally clotting in the test tube like a basketball net. So the manifestation which is present here is called as cobweb coagulum. This cobweb coagulum basically means that there's a protein plug. This protein plug will be suspended in the middle of the test tube and it will be hanging in the test tube upside down like a basketball net. It's because high concentration protein is present. Obviously, the pressure in the brain will be more and the color will be clear or straw color. Don't use color for diagnosis. Always use cells and use sugar. Now comes the core aspect. This was asked in FMG exam. He gave a question in which like maybe 25 to 100 lymphocytes were given. So a lot of my students, they said, sir, because it was 100 lymphocytes given, I answered it as a case of tubercular meningitis. One guy said, no, sir, the answer was not TB meningitis. I said, okay, why? He says, sir, because the sugar was given to be normal and you had told that viruses don't consume sugar. Bacteria consume sugar. Viruses don't utilize sugar for their metabolism. So sugar was given to be normal, and that is why the answer is not tubercular meningitis. It would be viral meningitis in a patient. Obviously, antibodies will be produced, so proteins will be more, but will never be in grams. There would never be a cobweb coagulum present. The opening pressure in this case would also be increased. So this would be a presentation of viral encephalitis. Important word of caution here is check out the values of sugar. The sugar values in this case would turn out to be normal for viral etiology. For fungal meningitis, I just want to add that sugar can be low, but the findings of viral and fungal meningitis will usually be identical. The only difference is in fungal meningitis, the sugar values would be low. I'll discuss the fungal meningitis in the later part of the discussion, but at the moment, I wanted to differentiate between TB meningitis versus viral because both are having lymphocytes present, but it is the sugar values that will differentiate and the amount of proteins. Plus, in TB meningitis, there would always be long history given. Tubercular meningitis, there will always be a mention of a relatively long history given, whereas when it comes to viral meningitis, it will be like 2-3 days illness, but TB is like 3 weeks illness, 4 weeks illness. So the history in TB meningitis would be spanning over weeks, but in viral meningitis it would be spanning over a couple of days. And now to see you got or imbibed this information, let's discuss this question. This came in NEET PG. 7-year-old kid and has been repeated in FMG exam. So you need to continue listening. 7-year-old kid has been sick for 4 weeks with persistent. 4 हफ्ते से बीमार है, बुखार भी है, irritability, vomiting, recurrent onset headache and neck stiffness. And the mother says like for एक दिन से तो he's not waking up, altered sensorium, not waking up. Lumbar puncture shows protein to be elevated, glucose of 30, 35, blood glucose is 100. So if you divide the two, then blood glucose divided by like the CSF glucose. So CSF glucose values would be 0.35, na? Like 35 divided by 100. I told you it should be less than 0.6. So it tells me that there is a bacterial infection present with lymphocyte predominant. It was only 120 cells, but if you look at it, CSF glucose is low. The CSF protein of this patient was not in grams, it was 180. That's okay, but it is still more than normal now. Normal is the 15 to 45. And then when you look at the cells present here, they were not like the values that I was telling you going up to thousands. Like it's okay, 120 cells, but they're a cause of concern because what is the type of cells? It is given as lymphocytic predominance. It is like when you count the number of cells, it is mainly lymphocytes that are present. The number of lymphocytes is given to be 120 and the history duration is approximately 4 weeks plus the CSF was given. You can see this dirty looking clot which is at the bottom of the test tube. This fell from the top of the test tube because when you shake the tube, the clot will fall at the bottom. This is a image based question of cobweb coagulum. A lot of guys solved the MCQ by just looking at the cobweb coagulum. A couple of more smarter ones said, sir, I was 100% sure because there was a slide also given. In this slide, you can notice that this is a Ziehl-Neelsen stain, that is Zn stain, which is bluish in color. And between that, you can see that red bacilli or Mycobacterium tuberculosis. So this is the red bacilli and the blue background. This is totally different from the Giemsa and the right stain that we use or hematoxylin stains that we use routinely or the gram stains that we use. I mean, the color of the blue and the color of red is totally different from all the traditional stains that we use in histopathology or hematology. So this is a Zn stain showing bacilli. So the diagnosis is like right in your face. It is going to be a tubercular meningitis. Along with this, in this question or in couple of other questions in the paper, they've also mentioned meningeal signs. Like in this question, I have not included meningeal signs information because then I would not have focused on the lab reports of this question. But yeah, I mean, these two very classical meningeal signs should be remembered. Let's have a look at it. Doctor is keeping one hand above the knee joint and one hand under the ankle of the patient, and doctor is extending the knee joint of the patient. You see, when person is having meningitis, there will be spasm of the hamstring muscles because the nerves coming out of the spinal cord are irritated. Therefore, due to meningeal irritation, the nerve roots coming out of the spinal cord are irritated when this muscle is in spasm. If you will stretch this muscle with spasm, it will cause change in the facial expression. The doctor will be looking at the face of the patient. The doctor's eyes are fixated on the facial expression. Patient will wince with pain. When you stretch the leg of the patient, when you extend the knee joint, stretching of the hamstring will cause wincing of pain by the patient. This I described to you is technically called as Kernick sign. How to remember Kernick sign? Just focus on the first two alphabets K and E. What you are doing in this case is a knee joint extension. You can see the doctor is keeping one hand above the knee joint and one below the ankle, and you are doing is a knee joint extension. And this knee joint extension, you are causing spasm of, you are stretching the spasm of a hamstring, and therefore this is gonna elicit pain. Knee joint extension will result in development of pain elicitation. The pain will be felt by the patients. They like, even if he's lying unconscious, no, the pain will be elicitable. So that's called as Kernick sign. Let's compare this with the next one. Here what the doctor is doing is assisted neck flexion. You can see one hand of the doctor below the neck of the patient. So what we are doing in this case is a assisted neck flexion, and the moment this is happening, there is a involuntary hip joint flexion as well as a knee joint flexion in a patient. If you check out the data, what you can see is the assisted neck flexion. This is associated with the involuntary knee joint flexion also and an involuntary hip joint flexion also. The combination of the two, involuntary knee joint flexion and the hip joint flexion, this is what is called as Brudzinski sign. These are signs of meningeal irritation. The examiner can use these signs in any case of raised ICP. In lot of questions of subarachnoid hemorrhage, he will be saying Brudzinski sign. Don't think that these signs are only for meningitis. They are general signs which are related to meningeal irritation. So any condition where meningeal irritation will be given. If I zoom out of the slide, the message is any question in which meningeal irritation is given. In any slide, if meningeal irritation is present, how will the examiner mention that meningeal irritation before you? He can write any of the following signs. The first sign of meningeal irritation is nuchal rigidity. For this, you will simply ask the patient verbal command, please flex your neck so that your chin touches the chest. Please flex your neck so that your chin touches the chest. This will require patient to be conscious. If patient is in altered sensorium, then in those circumstances, I will not be able to elicit this. So in an unconscious patient, what I can do is I can still be eliciting a Kernick sign. Kernick sign will cause change in the facial expression of a patient even if he is lying unconscious. And then if still in doubt, I can do a Brudzinski sign where a assisted neck flexion will elicit. Even the person is unconscious now, still there will be an involuntary KJ means knee joint and HJ means hip joint flexion. So these are signs of meningeal irritation that I've currently explained to you. Any of the three could be present. And one more point that I want to draw to your attention is that because in this question it is mentioned patient is in altered sensorium, I would not like to do a lumbar puncture immediately. First, I will be doing neuroimaging in this patient. This question asked me diagnosis, so I answered tubercular meningitis. But if he says, would you straight away like to do a lumbar puncture? No, I would like to first go ahead and check for the status of the ventricles. They'll be dilated on a CT scan, so we should give mannitol. Lower the pressure in the brain and then do a lumbar puncture in a patient. So if he specifically mentions, though this question did not ask it, if he says in workup pehle kya karoge, so you should be doing a CT scan in this patient. In fact, I can mention a CT scan ki finding also because we can give contrast also. Contrast in a CT scan in TB meningitis will be showing presence of basal exudates. The contrast in a CT scan will be showing presence of basal exudates. And then after the CT scan of the head has been done, I will then give mannitol to lower the pressure in the brain. And I'm just writing chota m to say that mannitol has been given. Diuresis has happened in a person. And then I can recheck the fundus. And then I can go ahead with a guarded lumbar puncture. So the message here is that any patient of meningitis, just remember that unfortunate case that happened with that boy who was studying abroad and they did lumbar puncture without taking adequate precautions. The boy went into respiratory arrest. That's a warning for all of us as doctors that don't rush into the procedure. Basal exudates word you don't read anywhere else for this patient. And for the treatment of this patient, obviously ATT needs to be given. If this is a two-step question, he will not even ask you the diagnosis. He will say not even ask you the workup. He will say what is the treatment that would be recommended. So for extrapulmonary TB, we have to give ATT for 1 year. And along with ATT with 1 year, we also have to give steroids. The normal, the teaching is that never ever give steroids in infection. But here we are bypassing this rule, guys. Because steroids will reduce the swelling in the brain. They will reduce the vasogenic cerebral edema. So additional point to be noted is Dexona will be given in these patients for 6 weeks. That would be initially like IV injections because patient is unconscious. Maybe if he regains consciousness, I can move on to oral, or I can put NG tube and continue with dexamethasone. ATT will also be given by NG tube in an unconscious patient. So for extrapulmonary TB, we need to give treatment for 1 year and Dexona for 6 weeks. Why steroids? In spite of infection, because you want to reduce the vasogenic cerebral edema. Though it would have been very easy for me to just to mark the word TB meningitis and move on, but I've been a little more descriptive explaining to you why the answer is TB meningitis, the lab evidence, what are the clinical signs that may be given in a question apart from the finding of nuchal rigidity, because unconscious patient cannot follow the command of flexion of the neck and making the chin touching the chest. And then basal exudates and the treatment part was also covered. Guys, for this particular slide, I know there would be a smile on your face because even if I start describing this case, you know the answer already. Your microbiology and pathology teacher has done an excellent job in training you that this is an India ink stain. India ink stain does not stain the organism, it stains the background, and the background is showing black color, and then you can see the capsule which is white in color around this yeast. So even if I don't go into the history of this question, just from India ink, you are able to pick up that the fungus or the yeast that we are talking about is by the name of Cryptococcus neoformans. Now at this moment, while I'm writing this, I want to bring to your attention that India ink stain is not the best way for diagnosis of this condition. Yes, guys, a lot of guys are under the impression that India ink stain is the best way for diagnosis of Cryptococcus neoformans, which causes fungal meningitis in immunocompromised patients like HIV positive patients. But actually, the best test for diagnosis of this condition is not a India ink. So I want to draw your attention to a test which has been extensively asked in both NEET PG and FMG exam, that is lateral flow assay. And this lateral flow assay can be done not only on the CSF sample but can be done on the blood sample and even the urine sample of the patient. So most of the questions on this topic will basically from the medicine perspective asking you not that what is the organism responsible, he will ask you what is the test to be done, and usually the answer in the app or in these PYQs will be urine lateral flow assay. Yes, guys, we're talking about a CNS infection, but the answer would be a urine lateral flow assay. Now let me read the question for completion. HIV positive truck driver, immunocompromised patient, came with fever and headache for the past 3 days. He has photophobia, so due to aversion to light, he cannot drive. And then doctor noticed nuchal rigidity. So the combination of fever, headache, nuchal rigidity is there. Then he's also talked about raised ICP, papilledema, CSF findings, MRI head is given in this patient. And in fact, one more finding which is given here is for mucicarmine stain. You see, if he says what is the stain that will be used for this organism, then your answer is not to be given as India ink stain, because as I explained to you and you know by default itself that India ink stain is a negative stain. It does not stain the organism. As I said, it will stain the background, that is jet black, and then you can see the capsule around it. So I'll repeat my statement. The black slide is obviously that unmistakable. The black slide is that unmistakable India ink stain, but it is not the best stain for diagnosis. If he specifically says what stain will be used to stain the organism, then answer is mucicarmine. So two must know informations right now, right here. Cryptococcal meningitis is present in HIV positive patients, that everybody knows. What he wants to see in the paper is that are you aware that you can do a urine test for this condition? Now you're aware of it. Urine flow, lateral flow assay. It's more accurate than India ink stain, and between India ink and mucicarmine, it is mucicarmine that will directly stain the organism, and in contrast, the India ink stain basically stains the background. Now comes the MRI head finding of this condition. Look at like this horrible image. This is called as soap bubble appearance. You read about soap bubble appearance, one in orthopedics with respect to X-ray of the hand with giant cell tumor, that is osteoclastoma. That I've not written because that is an orthopedic detail, but you are like just to keep a mental note of the fact that soap bubble appearance on X-ray hand is a feature of giant cell tumor. But if you read about soap bubble appearance on an MRI head, that it is always an answer of Cryptococcus neoformans meningitis. Then he will ask you what is the mode of entry of fungus into the patient. See, he might have got HIV infection via sexual route, blood transfusion, IV drug user, any of the following. But if he specifically says what is the mode of entry of fungus into the patient, then your answer would be inhalation of dust. You see, India is a very dusty country. No, you are studying in library maybe at the moment, maybe in your room. After one day, whichever table you are using, you touch it, there is dust present, omnipresent. You've been ever been abroad, even Dubai, there's hardly any dust. But in India, it's so much of dust present, and present in the dust is basically even pigeon droppings. Yeah, guys, lots of time, these pigeons, they make a nest on the top of our air conditioner, and through the filter of the air conditioner, it's not able to stop the products that are present. It could be histoplasma, it could be cryptococcus that is present. So inhalation of dust containing pigeon droppings is the reason why there could be development of cryptococcus neoformans. Even you and me can be having development of cryptococcomas in our lungs when we inhale these pigeon droppings. But because your and my immunity is very good, so cryptococcomas will be killed. But in this person, because immunity is less, so there is hematogenous dissemination. The infection which is developing in the lungs of these patients will then spread from the lungs via the bloodstream to the brain. The infection will cross the blood-brain barrier and go in the brain of the patient. I repeat my fact. I said inhalation of dust containing pigeon droppings will contribute to this person developing fever and dry cough. Even you and me can have fever along with dry cough for 1 or 2 days because of cryptococcoma formation in the lungs. But our immunity is very, very good. So therefore, these cryptococcomas in the lungs would be resolved. But in this particular patient, the cryptococcomas were first formed in the lungs. then because of the fact that the cell-mediated immunity of this patient, CMI stands for cell-mediated immunity of this patient, was reduced, so there would be hematogenous dissemination, and you can understand that if an infection is spreading via blood, then it can easily cross the blood-brain barrier, reach in the brain, and thereby cause meningitis. Inflammation of the meninges is the reason why, like, the guy was having nuchal rigidity. He can write Brudzinski sign, he can set Kernig sign for this presentation. Now, if he says what is the first investigation to be done in this patient, you can see two reasons why the answer is not lumbar puncture. First, immunocompromised state. The second is papilledema. I had taught you about a mnemonic, right? I emphasized on the pin word there, and you can notice papilledema is also given, immunocompromised state is also given. That is why the first finding that is given here is MRI head in this patient. MRI head will not only be used to pick up the soap bubble appearance, but it will also be used to pick up whether there is evidence of raised ICP, because ventricle size can be measured, and if the ventricles are dilated, I will give mannitol to decrease the pressure in the brain. After doing MRI head, the next investigation is a guarded lumbar puncture. By the meaning of the word guarded is don't withdraw the stellate immediately. Don't withdraw the stellate immediately. Let the CSF like come out drop by drop and in a test tube, and then send it to the lab for evaluation. As far as the CSF cytology of this condition is concerned, you can listen to this fact even if you don't note down the cytology part chalega, because ultimately the main test is still a urine or a blood lateral flow assay for antigenic detection. But to increase the length of the question, he might mention even in this question that the lymphocytes are present in the CSF. Along with this, when you read lymphocytes, your thought process would be कि यार ये तो viral भी हो सकता है, viral meningitis, or it could be like a TB meningitis. So he will then say sugar is low. So आपको लगेगा कि यार sugar low है तो viral तो हो नहीं सकता. It must be tuberculosis only, sugar is low. Protein will be elevated, but here the protein elevation will not be in grams. It would be like slight elevation. There would be no cobweb coagulum that would be given in this case. So when you read this report, it is a high probability कि HIV positive patient में TB भी तो हो सकता है ना. There can be TB meningitis also occurring in this patient. So first thought process of any doctor would be by seeing the CSF report that this is lymphocytes present, maybe 100, sugar is low, protein is elevated. So this goes in favor of like TB meningitis. But the point is that in this particular case, the number of lymphocytes will not be so high. The fall of sugar may not be very dramatic, and the protein may not be reaching up to grams. But still, to keep like that data in my mind is that it could either be TB or it could be fungal. How will I differentiate? Then I will go for the third test, that is lateral flow assay for antigenic detection of Cryptococcus. I have deliberately not written in the workup of this patient India ink stain, because the impression that comes is India ink stain is the best test for diagnosis of this condition. No guys, staining is never diagnostic. Just like if I say to you, what is better, gram stain is more superior or PCR more superior? Then PCR is more superior. Na? For any infection, PCR will be right on the top. Then I can do culture, then I can go for a gram staining. Similarly here, as compared to India ink stain, it is the lateral flow assay that would be present, and the CSF finding in this condition can be a distraction given in the question. Low lymphocytes increased, sugar low, and protein elevated could make you think in terms of TB also. But then for TB, he should then be mentioning regarding PCR, CSF for tuberculosis, Mycobacterium tuberculosis, or he should mention CBNAT. In fact, if in doubt, I can do a CBNAT in this guy also. CBNAT is cartridge based. Government of India guidelines, na, CSF, CBNAT would be done in this patient. In fact, I can just go back to my TB discussion and say to you that overall, if he says what is the best test for diagnosis, though we had evaluated the patient on the basis of basic lumbar puncture in the CSF findings and we go ahead, but if required, like if the examiner goes into that evidence-based medicine, then on this guarded lumbar puncture, जो CSF का sample है, उसके ऊपर मैं क्या टेस्ट कर सकता हूँ, तो आई कैन बी गोइंग फॉर अ कार्ट्रिज बेस्ड न्यूक्लिक एसिड एम्पलीफिकेशन टेक्नोलॉजी फॉर माइकोबैक्टीरियम ट्यूबरक्लोसिस. टू बी श्योर, द लर्निंग पॉइंट फॉर यू गाइस इज कि HIV पॉजिटिव पढ़ के डोंट एज्यूम इट इज क्रिप्टोकोकस. इट कैन बी TB ऑल्सो, it can be it could be cryptococcus also. How do you pick up cryptococcus? अगर वो इंडिया इंक दे देता है फिर तो यार सुपर इजी हो गया ना. If he gives himself India ink, I mean this is gonna be a super easy case for me. I'll never have a challenge. But my point is, if India ink is not given, you should be able to pick up the mucicarmine stain. You should be able to pick up the soap bubble appearance, and then more importantly, a lot of these questions will revolve around what I said subsequently, urine, your blood sample, because like thought process of anybody whenever you are dealing with the CNS question is कि यार सब कुछ CSF से होगा, but then like we have a test which is good enough and can be, because ultimately there is a hematogenous dissemination, the infection is going into the brain via the CSF. Now for the management of this patient, we will be giving liposomal amphotericin B, and the second molecule that is used here is called as 5-flucytosine, not to be mixed up with 5-fluorouracil. That's obviously an anti-cancer drug, so there is no reason. The pharmacologist has done an excellent job here, that even before I would have written this data, like you guys would have been in your mind saying, no sir, we know the answer to this question, aage chalo. So flucytosine is the drug that would be used initially for 2 weeks. Initially, we admit these patients, and for first 14 days, we give them IV antibiotics, that is antifungal drugs, liposomal amphotericin B, 5-flucytosine. Then on discharge, when this patient will be sent back home, at the time of discharge, you will be writing a oral drug for this patient. The oral medicine that is given is fluconazole. This oral fluconazole is to be given for another 10 weeks. So the total duration of treatment for this condition is 3 months. That is 3 months. And like because CD4 count is low, so he will continue to develop a recurrence of this also. Sometimes we might continue fluconazole even longer than 3 months in these patients, depending on the CD4 count. But the main aspect to be remembered from the treatment perspective is that fluconazole is a fungistatic drug. It is not a fungicidal drug. So initially I'll be like ballistic, aggressive. I'll be using liposomal amphotericin B with 5-flucytosine, and then oral fluconazole would be given for 10 weeks for these patients. So that's the treatment algorithm. 2 must know facts on this discussion is: 1, how did he get the infection? Then it is inhalation route. There was cryptococcomas that had a hematogenous dissemination. That's part number 1. What is the best test for diagnosis of this condition? Lateral flow assay on a urine sample or on a blood sample, or if possible on a CSF sample, because patient may not give consent for a lumbar puncture. Second point, and initial management is not fluconazole. Initial management is liposomal amphotericin B with 5-flucytosine. Now we come to brain fever again. इंडियन पर्सपेक्टिव, विलेजर विद 1 day हिस्ट्री ऑफ हाई ग्रेड फीवर, एक दिन के बुखार में अनकॉन्शियस हो गया, अनरिस्पॉन्सिव हो गया, घर वाले शॉक में है, सर माय सन वाज फाइन, एंड विद इन 1 day like he is like patient from a village and he is not recognizing his parents, nuchal rigidity is not there, so it is not meningitis. The workup shows low hemoglobin, elevated LDH, KFT is normal, LFT shows unconjugated elevated bilirubin. So let me explain to you why this workup is given. But before that, let me highlight the blood work that was also given in the question. These 2 images are from 2 different exams, but they are dealing with the same thing. In the first image, you can notice very classical banana-shaped gametocyte. In the first image, you can notice banana-shaped gametocyte of Plasmodium falciparum. So what I'm talking about as brain fever is cerebral malaria. What you can see here is a banana-shaped gametocyte, the ones that you can see at the moment along with RBCs. This is very, very classical for Plasmodium falciparum. In the second, in a different year in the exam, they did not mention these banana-shaped gametocytes. But if you look at the image here, in the red blood cell, I'll use a finer font here. In the red blood cell, you can notice presence of multiple ring stages. Like if I zoom in, I can say that this looks like a wedding ring, and there are multiple wedding rings. Like even here, if you look where I put the arrow at the moment, you can see two rings, wedding rings present inside the red blood cell. This again is suggestive of falciparum infection. And in villages, I can say because the mosquitoes are like the tree cover will be more, water bodies will be more, so mosquitoes will also be more. So falciparum malaria can occur. The image in this case shows banana-shaped gametocyte. The second one shows what is called as multiple ring stages. The second one shows what are called as ecole forms or multiple ring stages of falciparum malaria. And for detection of this condition, if I don't have facility of like I can say these microbiological backups, then I can go ahead with the dipstick also available, CAR test or dipstick available, histidine rich protein 2 dipstick. I mean, 2 tests that have been developed by Government of India. One is RK39 antigen for Kala Azar. Second is histidine rich protein 2 for detection of falciparum malaria, because it is so common. See that facility from microbiology perspective may not be available 24/7. Like patient came today evening, maybe at 9 o'clock in the night, then there would be no microbiological backup were available before me. The microbiological lab will open day next day morning. So this is ideal situation that I can get a peripheral smell finding a multiple ring or echo stages visible for Plasmodium falciparum. Otherwise, I can use that card test where with only few drops of blood, I'll be able to identify that patient is having infection with this dangerous parasite. See, what Plasmodium falciparum does is that it makes the RBCs very sticky. And because RBCs are very sticky, so at the chota blood vessels, let us imagine ये छोटा छोटा blood vessels है brain की. So these RBCs are very sticky. So because of the stickiness, the circulation of the brain will become very sluggish. And when you have sluggish blood supply in any area of the body, when you have sluggish blood supply of the brain overall, it will cause a global brain dysfunction or malfunction. And that is why the person is turning unconscious. I repeat my statement. Plasmodium falciparum, what it does is it will make the red blood cells become very sticky, and because of the stickiness, there would be sluggish circulation overall in the whole of the cerebral cortex. If the brain's blood supply, global circulation of the brain becomes sluggish, then the person will go into encephalopathy. He will go into a altered sensorium. So the clinical presentation given in this patient is of cerebral malaria. In the MCQ, if he will not give you histopathology, I'm erasing it because histopathology will be written once again in the slide for practice sake. Sometimes they may not give you these histopathology, they may not give you these blood slides. They will expect you to solve on the basis of the blood work given. Check out the blood work here. Hemoglobin is less and LDH is elevated. He is giving you hemolysis evidence in this MCQ. Falciparum malaria will ultimately cause destruction of red blood cells. So what is the hemolysis evidence? That when RBCs will break down, what is present inside the RBCs, LDH. So LDH will begin to rise. And when RBCs get lysed, then unconjugated bilirubin in the body of this patient will rise. You can see that the KFT of the patient is standing normal as of now, but unconjugated bilirubin is elevated because of hemolysis. So I want you to be able to solve this question on the basis of the following hints. The hint number one in the question can be that he can give you this banana-shaped gametocyte, pretty cool, pretty straightforward, and easy to remember. If he's not giving you banana-shaped gametocyte, then the peripheral smear will be showing multiple ring stages. Even if it does not give you these multiple ring stages, still you can solve the question because there is evidence of hemolysis given in the question along with fever in any patient in India, especially like from a village where I said like more trees, more water bodies, more mosquitoes, and evidence of like global CNS malfunction. That global CNS malfunction is because RBCs are sticky, so there would be like overall under perfusion of the brain. I'm not saying any blood loss from the body. I'm just saying overall there is a global perfusion of the brain that is lesser, which is causing an encephalopathy. This entire presentation is what is called as Dimagi Bukhar in India, that is cerebral malaria. In some questions, he might say that in emergency, what test can be done for identification of this condition? Then I have already told you that we have a card test available. It is called as histidine rich protein 2 card test, where with like few drops of blood only you can diagnose this condition without microbiological extensive workup being available. Or the question will say what is the treatment of this condition. So I would like you to read about the treatment from the PSM domain, but you would be aware that आजकल तो कुनीन तो काम करता ही नहीं है ना, whether it is northeast or any part of India. So we will have to give IV artesunate to the patient. If I can't secure IV line, because lots of time these patients might be in circulatory failure, I can give intramuscular artesunate for management of this patient. So now you know two reasons why person can be having high grade fever with altered sensorium. One is herpes simplex encephalitis. There also no nuchal rigidity is present. Nuchal rigidity, you can see in this question, nuchal rigidity in this question is given to be absent. Nuchal rigidity is a feature that is seen in meningitis but is not seen in encephalopathy. It is not seen in encephalitis. So every time you get this first line of the question, do remember 1 day history of high grade fever with altered sensorium, and he says MRI shows temporal lobe inflammation, lumbar puncture shows bloody CSF, EEG shows blood. Answer herpes simplex encephalitis. If he gives you the blood work findings or he gives you hemolysis evidence, any one of these informations which are given to you, then you can safely say that I'm dealing with falciparum malaria, that is cerebral malaria. We call it complicated malaria primarily because of this reason. And I would like to worsen this case further by saying even KFT can get deranged. How? Because when hemolysis will occur extensively, then hemoglobin will come in the blood. Hemoglobin will block the tubules of the kidney, and this patient can be having passage of black color urine, that is called as black water fever. I have not written it at the moment because I'm saying that this is a standard CNS case, but there can be deterioration. I'll say the deterioration again. जब RBCs टूटेंगे तो क्या बनेगा? Hemoglobin. Hemoglobin will now like be filtered through the glomerulus and will come into urine, and hemoglobin is not red, it is brownish black in color. So possibility is that in this case there could be mention of black urine, or even if not black urine, KFT can be deranged, no, because hemoglobin is a high molecular weight compound, so it can block the tubules of the kidney physically. It will cause acute tubular necrosis, and that tubular necrosis will be then responsible for a renal shutdown. So don't be surprised if in this question KFT is deranged. Yeah, kidney can be involved. There can be metabolic acidosis. Again, why? Because kidney is getting deranged. So if he wants to make it more like technically more challenging for you, even the description of hemoglobinemia, hemoglobinuria, black color urine, and acute kidney malfunction can be given. In all of these cases that I described before you, we had to do a lumbar puncture eventually. The preferred site for doing a lumbar puncture is L3, L4. Usually the needles that are used for doing lumbar puncture in a patient sometimes can be very pointed, and the pointed needles, the problem will be that they'll cause a hole in the dura mater. So lumbar puncture, after lumbar puncture, headache will be a big problem. If you look at this pointed needle, this pointed needle is also called as a traumatic lumbar puncture needle. We call it Quincke's needle. This Quincke's needle has a disadvantage that the cutting edge of the needle is very sharp. So it can contribute to like a big hole created in the dura mater, and continuous CSF leakage can be present. To minimize this, there can be a second needle that can be used, which is called as Sprotte. In Sprotte, like the tip is not like, in Quincke's, if you look at it, the tip of the needle, if I just make it here, the tip of the needle is actually having a double-edged cutting blade. If you look at it, the tip of the needle, I'll just redraw it again. It's already there, but like just for representational purposes, you can see that it's a very sharp blade, double-edged cutting blade, and this will poke a hole in the dura mater of the patient. So I want to avoid using this needle wherever possible, and I can use a Sprotte's needle in a patient. So always, whenever you're doing a lumbar puncture, first use a thin bore needle. Use the thinnest possible needle, not the thickest needle. Use the thinnest possible needle, and between the two needles, if he says which of the two would be recommended, then Sprotte's needle will be recommended because it causes less trauma to the dura mater. Contraindications to lumbar puncture, the first one I've already explained to you. I also explained about that student who unfortunately died. Raise ICP, you put a needle, patient will die. Then can be local site infection. Obviously, like India is a very sweaty country, so on the back of the patient there can be small pustules present. If you put the needle through this, Staph aureus will go inside. So I'll not do a lumbar puncture. If somebody is having a deformity in the spine, I will not do a lumbar puncture. Raise ICP is something that students don't forget. 2 and 3, they don't ask usually. What they will ask you after raise ICP, the second important absolute contraindication to lumbar puncture. I gave a hint also, bleeding diathesis. Before you poked in the needle, always make a point to ask the relatives of the patient that is he on any drugs which have been prescribed by any cardiologist to decrease the tendency of clotting. I'm not talking about aspirin. Aspirin, if being taken by a patient, I don't have an issue. But if warfarin is being taken, apixaban is being taken, I do have an issue here. So the word here is bleeding diathesis, because if I put in a needle with person with bleeding diathesis in whom international normalized ratio is elevated, the tract created by my needle will cause local bleeding. Plus the bleeding can expand and it can press on the nerve roots which are coming out of the spinal cord. So neurological deficit can occur. So point number 1 and 4 are like must know facts for you guys. All of these are absolute indications, contraindications for lumbar puncture in a patient. And then for like the surface marking, you can see that this is the iliac crest. So I will be making the patient lie in a lateral decubitus position. Then I will also ask the patient to flex his knees so that the knees touch the chest. So from the position perspective, like first you will tell the patient, you have taken the consent already. You will request the patient to lie on his side. You can do lumbar puncture in a sitting position also, but if a person is drowsy or a patient is not well, then making him sit would not be a good idea. So lateral decubitus position can be used. You will ask the patient to flex the knees so that the knees are touching the chest. So it's more like a curled up fetal position, that is knee chest position, and then gentle neck flexion. Don't put too much pressure on the neck of the person because he's having nuchal rigidity. So from the positioning perspective, first I have like made the patient a little comfortable by lying on the edge of the hospital bed. I will give local anesthesia before I put in the needle. And as far as the surface marking is concerned, I will select the highest point of the, if I zoom in, I will select the highest point of the iliac crest. I will draw imaginary line that is joining the two. He will ask you from the anatomy perspective, what is the name of this anatomical line which is starting from the highest point of the iliac crest. It will be cutting through the L4 vertebra. It is cutting through the spinous process of L4 vertebra, and usually the lumbar puncture is done just above it, that is L3, L4, or can be done just below it, that is L3, that is L4, L5. So this line from the anatomy perspective is what is called as Teuffier's line. Teuffier's line is an anatomical landmark. This is what is the reference point with respect to performance of a lumbar puncture. If we are putting the needle above this, that's the routine norm. If we go just below this, that is, if I put the needle here in this area, then this would be L4, L5, and if I put it above this, that is L3, L4, any of the two sides can be used. L3, L4 is the one that is usually recommended. So anatomically speaking, Teuffier's line is what I spoke about. We made the patient lie in a lateral decubitus, knee, chest, and a neck flexion after taking consent. As I've explained to you, I'll just write the name once again. The name of this anatomical line, highest point of the iliac crest joint to form Teuffier's line. It cuts through the L4 spinous process. The most common complication of lumbar puncture is headache, and best drug for management. Okay, that's another important aspect. Like headache is occurring. So what can we do to prevent it from happening? If he says from the prevention perspective, what would you like to do? Then the first thing is always use a thin bore needle. Then the second aspect is which type of needle would be recommended. Would you recommend a Quincke or a Sprotte? Then we would prefer a atraumatic, that is Sprotte's needle. So second point is preferably use a thin atraumatic needle. 2 points. The third aspect is for the prevention perspective. After the procedure has been done, always advise the patient strict bed rest. When the patient will lie straight in the bed, the pressure over the site where you have poked will form a clot, and that will prevent the leakage of leakage of the CSF. So strict bed rest must be done in this patient for minimum at least 8 to 12 hours, so that I can ensure a big clot developing over the site of the puncture, and the prevention of leakage of CSF can be like circumvented or prevented. Now, in spite of all this, if this is happening, then I will first give hot tea and coffee to the patient, because caffeine also has an analgesic effect from the CNS perspective. But in spite of that, if like patient is still having issues, then I will have to get IV caffeine. Here we should avoid using opioids. Opioids cause constipation. Constipation will cause straining, and it will dislodge the clot that is formed at the site of the puncture. That dislodgement of the clot can again cause leakage of the CSF. So he says avoid causing the patient to strain, because opioids, like you can use tramadol, you can use codeine, but the side effect is constipation. So yeah, in extreme cases, I might be trying to use even like I might plan and try and use codeine in a patient or tramadol. But wherever possible, if between opioids and caffeine I'm giving a choice, I will be selecting caffeine for management of this patient. And if he says what is best for prevention, then don't answer caffeine. That is the treatment part that I'm talking about. Prevention is thin bore needle wherever possible, then is as thin bore as possible, then is atraumatic, strict bed rest. The combination of these would go a good way in preventing aspects from occurring. Plus hydration part is obviously to be maintained. And I can also make you practice what are the layers through which the needle will be going inside. So obviously when you will be putting the needle, initially the layers that will be pierced would be the skin and the subcutaneous tissue. But after that, your needle will have to go through a couple of ligaments, and the name of these ligaments, that is 2, 3, 4, are the ones which are to be given a priority. First, the needle will be going through this area that I'm marking in color blue. This is what is called as the supraspinous ligament. So whenever you do the procedure, don't try to like push the needle very fast. Feel each of the layers, go layer by layer, and you will be able to overcome the resistance, because the cutting edge of the needle is designed in such a fashion to overcome the resistance. So you'll pierce the supraspinous ligament. After that, you will reach this area where maximum resistance will be felt by you. Your needle is now traveling through the yellow area that I'm marking at the moment, and this is what is called as the interspinous ligament. So first the needle goes through the supraspinous ligament, then it goes through the interspinous ligament. This is where the maximum resistance is felt, and most people tend to feel at this point of time that, oh, I have not reached the right space. Just be patient. When you pierce this, you will be now breaching the last layer. The last layer that you're breaching is the one that are marked in purple, visible. This one is called as ligamentum flavum. So the orientation of these From outside to inside is what is of paramount importance, that we start from outside, from supraspinous ligament, then interspinous ligament, then ligamentum flavum. And once you have pierced the ligamentum flavum, guys, you will suddenly notice things will become easy, because now the needle will be touching, the tip of the needle will be just ready to pop the dura mater. I'm just saying the word popping the dura mater. We don't need to apply any force. The cutting edge of the needle itself is so sharp that it will navigate through the dura, and behind that is the precious fluid that you're looking for, that is the cerebrospinal fluid of the patient. This is dura mater. Now I'm marking in purple color just behind the dura mater. This red layer that I've shown is the last layer beyond which the needle of yours will be reaching the subarachnoid space. This red marking that I've done, or the purple marking that I've done, is the arachnoid layer, because dura is adherent to the arachnoid layer. And just behind this is the fluid that I'm looking for, that is subarachnoid space, is where the CSF is located. So from outside the inside, I have mentioned the layers, like they can jumble up this data. Initially this will look very simple to you, that oh, what is the big deal, but then I want to say that you should be having a mental note of this, whether he mentions from when he will jumble it up, it will cause an issue. So the layers pierced during performance of a lumbar puncture are skin subcutaneous, supraspinous, intraspinous, interspinous, ligamentum flavum, dura, and the arachnoid layer. And you hit the CSF. You will be collecting the CSF in total of 4 bottles. The first test tube in which you collect the CSF of the patient, right? It comes drop by drop. Don't withdraw the stellate completely. You will label the test tube. The first test tube will be labeled for evaluation of the CSF sugar as well as the protein. We will send it to the biochemistry department for estimation of sugar and the protein. The second sample, that would be again something like about 5 ml or less than that, you will be sending this for CSF cytology. So this would be sent to the pathology department, because they're good at seeing the slides. You want to see whether it is neutrophils or lymphocytes that are present. The third test tube that you will be sending will be for CSF culture to the microbiology department, because as an intern you are supposed to label the tube. So you should know that the first tube is not for culture, first tube is for biochemistry. Second tube, the B number tube, is for cytology, and tube number C is for CSF culture. The fourth and the last tube you will ask your nurse to store in the refrigerator for later usage. This is for special studies. What I mean by special study is that at a later point of time, if your consultant is asking you to get, let me say, CB-NAT done on the CSF sample, or he says get a India ink preparation done on the sample, then we will be using test tube number D. This last tube that I mentioned is for special studies. What is the special studies that can be done are like CB-NAT, cartridge-based nucleic acid amplification technology, or that is for Mycobacterium tuberculosis, or we can be using India ink stain, or we can be doing like PCR herpes simplex. So the point is the CSF that is collected will be collected in total of 4 tubes. Max amount of CSF that you can remove is about 20 ml. So you can take 5 in each one of them. The rate of CSF production in our body is 20 ml per hour. So even if you remove the 20 ml, it will be produced again. The total amount of CSF in your and my brain is 150 ml. Total amount of CSF present in our brain and spinal cord total is 150, and the rate of production of CSF is 20 ml per hour. So even if you remove like total 20 ml, it will be produced back in next 1 hour. Because a query that I get was, sir, you are removing CSF, will you not lower the pressure of the brain less than normal? No, you see, elevated pressure, I don't do the procedure. I first give mannitol, cause diuresis, get the pressure back to normal. Once the pressure is normal, I remove 20 ml, it will be produced again, and the max amount of CSF that I can remove is about 20 ml. Now, in the light of this technical aspects of lumbar puncture that I've discussed, we'll talk about another CNS infection in Indian patients, that is neurocysticercosis. And the slides are very, very characteristic. At this moment, I can see a MRI head. In the MRI head, these black areas that I can see are called as hypointense lesions. This is where the eggs of Taenia solium are like hatching into a larva. Some of these black areas are having that white dot also present. Like you can notice a white dot at the arrows that are marking at the moment. That is the Scolex. So what is shown in this image is obviously neurocysticercosis, but what is shown here is technically called as, I'll write down the data here. What you can see here is multiple hypointense lesions. This is classical. I can call them black holes. Hypointense lesions are like black holes. And some of these hypointense lesions are also having a white dot. For that white dot, I would like to say that because the white dot is towards the periphery, so I've written the word eccentric scolex. It is not necessary that it will always be in the periphery, but yeah, usually. So the moment you read this MRI report that says hypointense lesions seen in a patient with seizures and eccentric scolex, you know that you're dealing with neurocysticercosis. And also here you will have to use albendazole for management of these patients, because the infection is very much like present and you need to kill the worms. Before I focus on the x-ray, I want to just move on to a image of the same patient, maybe done 6 months or 8 months later, where you can notice multiple calcified lesions. If in the exam he will give me these calcified lesions, and then I can like safely say that the parasite is dead. It is intracranial calcifications that are present here. Obviously, this entire description is what is called as starry sky appearance. But in exam, he will not be interested in that starry sky appearance. That he knows that you will answer. What I want you to appreciate is that if we will give and mention the word only intracranial calcification or calcifications are present, obviously these calcified spots will act like a epileptogenic focus and will cause seizures. But now you don't need to give albendazole. Guys, you don't need to give albendazole if the worm is dead, if the parasite is dead. If I look at this image, image A versus image C, there would be a difference in the treatment in both of them. In A, I will be giving patient albendazole plus I will be giving sodium valproate to the patient because he is having epilepsy. But in C, there is no role of albendazole because the parasite has already died. Most questions on this topic revolve around the fact that the doctor, whosoever will read neurocysticercosis, that doctor will have a reflex to answer that, oh, I need to kill the infection, I will give albendazole. Yeah, you will give albendazole. But if it is only calcification, that means that the parasite is already dead, then you don't need to give albendazole, then it is only valproate that would be given. I'll jot it down subsequently, but between A and C, I wanted to say that both of them are called as starry sky. Now those days are over. Naya starry sky appearance to in previous 5 years I can say I have not seen questions saying starry sky appearance of the brain showing neurocysticercosis. If things were so easy, we would not be having such discussion. I would have simply told Ratlo, yaar, starry sky appearance is a feature on neurocysticercosis, move on. He wants you to analyze the report and answer. Now look at the image number B here. In image number B, it is cysticercosis. These larvae are dying in the muscles of the patient. These larvae, this is like a calcified larva. They have died in the muscles of the patient because security system has attacked them. They look like either cigar bodies or they look like rice grain calcification. For this rice grain calcification, I can say that now I am dealing with a case of cysticercosis. Earlier, I was saying the word neurocysticercosis for A and C, but for B, I am saying the word cysticercosis. So in this particular case of cysticercosis, the drug that I'll be answering is not albendazole. I will be answering praziquantel. The answer is praziquantel is used for treatment of cysticercosis. For neurocysticercosis, it is combination of albendazole with praziquantel. I've upgraded your knowledge base. If I suppose I asked you, how do you treat neurocysticercosis? Then answer is not albendazole alone. It is a combination of albendazole with praziquantel. The rationale is that if somebody is having an infection going in the brain, that he will also be having it in the skeletal muscles. So you must give two drugs. One that acts on the muscles where the larva is present. Second, that should act on the brain, that is albendazole. So for A, I will answer two drugs now, albendazole with praziquantel. For B, I will give only praziquantel if he gives me only X-ray of the extremities showing rice grain calcification, because that is diagnostic of cysticercosis. And if he will give me calcification, then I don't need to use any of the two drugs. Then I will be using sodium valproate for these patients. Moving ahead, I just want to show one more image where this white dot can be seen. That is the eccentric scolex that is developing in the multiple areas of the brain. So this gives me an opportunity to say that just like you can't count the number of stars in the sky, though all of these appearances that I've described before you are starry sky appearances, I initially wanted to tell you about the diagnostic importance of each one of them. And now as the general word starry sky appearance on an MRI head indicates a diagnosis of neurocysticercosis. At this moment, the query of a lot of students is, sir, why can't it be a tuberculoma? It could be a related to manifestation related to TB also. So TB usually will not cause that white dot to come. It will cause those black lesions to be present. But like how will a doctor differentiate whether it is, suppose it's a single lesion only. Multiple lesions, okay, neurocysticercosis you can identify, but if it's a single lesion only, like lots of time in India, focal seizure, single lesion could be there. So he is asked specifically in the exam. This was a NEET PG question. How will a doctor differentiate whether it is a single lesion or neurocysticercosis or is it due to tuberculoma? Your answer will be we will be doing a MR spectroscopy. Yes, guys, one of the most important data for this particular topic is MRS. Magnetic resonance spectroscopy is used to differentiate between whether person is having presence of neurocysticercosis or it is tuberculoma. If the MCQ says MR spectroscopy shows a lipid peak, if it says MR spectroscopy shows a lipid peak because TB bacteria are having, like the cell wall of TB bacteria is rich in lipids. So therefore MR spectroscopy will be, if saying lipid peak, it goes in favor of tuberculoma. In contrast, if you read a question that says MR spectroscopy of a patient, even if it's a single lesion present or multiple lesions present, it says amino acid peak. Then amino acid peak would mean that you will now be answering this as the topic of interest, neurocysticercosis. Let's revise the outputs that I have provided to you. There are A, B, C, D, total 5 images that are given here. The first image is that of hypointense lesions with the eccentric scolex. So I can say this is neurocysticercosis, for which I'll be using albendazole with praziquantel. I'll write it down, don't worry. B is praziquantel alone, that I have highlighted already. C, I don't need to kill anything, it's already dead, so I'll give valproate. D is just standard statement for star sky appearance, and if ever in doubt, run a MR spectroscopy. This MR spectroscopy is a test that helps in differentiating. This MR spectroscopy helps in differentiating whether it is a tuberculoma versus neurocysticercosis. If you read lipid peak, tuberculoma. If you read amino acid peak, neurocysticercosis. Now let's look at like the data which is to be answered. If only calcified lesions are given, then valproate should be given for minimum 2 years. This I've already explained that GTCS is one of the common presentations. Most common cause of acquired epilepsy in India is neurocysticercosis. It is caused by ingestion of proglottids containing the exotaneous volume. It is consumption of the, not pork. It is not pork eating. It is the consumption of proglottids containing the exotaneous volume, which is the reason for like the manifestations occurring in this person. If he gives you hypointense lesions with or without scolex, then if he says what is the first drug, then don't ever answer albendazole. Now here you will say, sir, you were so vocal about albendazole. Yeah, I was vocal about albendazole earlier, but I want to handle one more problem, that is that of cerebral edema. Because wherever there is a worm, like suppose I draw this black area again, this was the black area. Then inside this, there was that eccentric scolex. But when I will be doing a MRI with contrast in this person, then I'll be able to demonstrate this cerebral edema. Wherever there is a parasite present in the brain, there will be a fight between the security system as well as the parasite going on, which will cause this vasogenic cerebral edema. This vasogenic cerebral edema that I've currently marked before you will not be seen on a plain MRI. It is on a contrast based MRI. So first we will do a plain MRI, then we will give IV contrast to the patient, and we will be able to demonstrate this vasogenic cerebral edema. This is the reason why the neurons are getting irritated, and the irritation of the neurons is then causes seizures in a patient, because after all patient is having epilepsy now. So initially I need to control the seizures and decrease the vasogenic cerebral edema. So what will we give? Dexamethasone injections intravenously will be given to these patients for minimum at least 2 to 3 days. He has asked specifically that for like कैसे management करोगे? So for the first 48 hours, I will give dexamethasone injection 6 hourly to the patient to decrease this cerebral edema. When the cerebral edema will decrease, then in this patient of neurocysticercosis, I will be using albendazole, and along with albendazole, the second medicine that I'll be using is praziquantel. So if it is more than one lesion present, single lesion, you can give albendazole. Multiple lesions, it is albendazole with praziquantel that is given. The rationale that he says is that if somebody is having so many lesions in the brain, then he must be having lesions in the muscles also. So albendazole with praziquantel would be used. And then in this patient, sodium valproate will be introduced, which will be continued for minimum of 2 years. And you will always explain to the patient that, sir, if you don't trust me, then don't follow my advice. Because if you will suddenly stop, Then you will develop GCSE. That was the first thing in, like when I was describing seizures to you, I told you generalized convulsive status epilepticus. Remember, that was an FMG exam question. Patient having seizures, we have to give lorazepam. We need PG. That was like he said, what do you do after this? Then we give a second shot of lorazepam. But like this is the treatment algorithm which is to be remembered for the aspects of for the diagnosis of neurocysticercosis, NRS. That MRS will help in differentiating between whether it is neurocysticercosis or a tuberculoma. There are multiple other differences also, like tuberculoma, whenever it is present, the size will be relatively bigger. It will be associated with meningitis, posterior fossa is involved. And then the gold standard investigation, why it's used for differentiation is because MR spectroscopy talks about the behavior of the lesion in the brain. It can pick up a lipid peak versus amino acid peaks for neurocysticercosis. The locations, etc., are also important, but if it's a single lesion given, if it's a large lesion present, like you'll notice one of the PYQs of AIMS, no, it's a single lesion, very large one, more than almost 3 centimeter big. Marking is also given 3 centimeter big. NCC lesions are not 3 centimeter big. Here it is like a big single lesion present, and he also mentioned MR spectroscopy shows lipid peak, so the answer would be given as tuberculoma. Otherwise, for neurocysticercosis, the details have been mentioned. The most important thing that I want to highlight is that the answer for the treatment of this condition will depend upon how early or how late the patient has come. If patient will come to me very late with only calcification, then I don't need to give anti-parasitic drugs to the patient. I don't need to give even steroids to the patient because there is no cerebral edema. This is a very late manifestation. That is why CT scan is not the preferred imaging modality. CT is very, very good for calcification now. So because he will write calcification, तो बहुत सारे डॉक्टर क्या करते हैं, they answer CT scan as the best imaging modality. No guys, it is MRI, and that too not a plain MRI. It is a contrast based MRI. So I'll just write it for the sake of completion, though it's very clear. Imaging modality of choice to identify neurocysticercosis would be answered as gadolinium enhanced MRI. He will also ask you here that what is the finding on gadolinium enhanced MRI that you'll be seeing. Then it would be a vasogenic cerebral edema. In medicine, we call it vasogenic cerebral edema. Radiology people call it ring enhancing lesion. वो ऐसा लग रहा है ना जैसे कि there is a ring around it and there's a lesion, right? The parasite is, the white dot is the scolex. The black is the local destruction that is caused while the parasite is proliferating, and then the body is reacting against it by the security system coming in. So this looks like a ring around the lesion, so we call it a ring enhancing lesion. I've not written that word because that's what is used by that's a word used by radiology people. In simple English, we just call it a vasogenic cerebral edema. I need to suppress it. This is the reason for development of seizures in this patient. That is why I opened my discussion by saying to you, first line in neuro मैंने क्या बोला था, most common cause of acquired epilepsy in India is neurocysticercosis. I need to suppress the vasogenic cerebral edema. So आपने देखा कि यहाँ पे जो आंसर था वो एंटी पैरासिटिक ड्रग्स नहीं है, स्ट्रेट अवे एंटी पैरासिटिक ड्रग्स नहीं है. एंड इफ अ डॉक्टर इज नॉट पेइंग अटेंशन टू दिस, उसने ओपीडी बेसिस पे नो, वी नेवर ट्रीट एनसीसी. Like if a doctor will give albendazole praziquantel on OPD basis to this patient, then obviously you will kill the parasite, agreed. But when you kill the parasite, the products released from the death of this parasite cause more swelling in the brain and the seizures will worsen. So it says admit the patient, decrease the swelling, then give albendazole with praziquantel, then give valproate. And if he says only that calcifications in the brain are present, then answer is like I will give only sodium valproate because calcification is also acting like a epileptogenic foci, and the lesion in the middle, that is option number B that is shown here, is rice green calcification where only praziquantel is shown. I have not written it, but it's clear it is cysticercosis. Obviously because brain is not involved, and most cases have a combination of the two, so that's why two drugs were combined. So this is like I can say like I was so expressive about this infection is because so many years have passed since independence, but hygiene part in India is literally like, even if you go to good chains, they don't even wear gloves while handling your sandwich and making your coffee, If you ask specially and say that why are you not using gloves, they look at you like this. कि वे क्यों मांग रहा, ज़्यादा सफाई चाहिए. I mean, it's like crazy, I mean, it's a basic thing that they might be using gloves and they might be taking cash from you, handling your credit card, right, punching in the machine, and then using the same hand to handle the sandwich, and you ask them कि क्यों कर रहा है, so they are like अच्छा बहुत, that the look, they'll obviously change the gloves, but the look would be like, why are you being so finicky? I mean, that's why Gora people make fun of Indians. Now that hygiene part, I mean, handling of food, why should hand be touching the food? And if somebody's nails are not cut and he's having this infection, he'll transmit it to my sandwich also, no? I'm saying even in a big chain, man, if you have somebody who's working and he's not following hygiene and his nails are dirty, he could be having proglottids below his nails. Now he's using his hands to handle my sandwich. He cuts it. The proglottids get transmitted to my sandwich also. No, so I'm not saying that this disease would occur only in like low socioeconomic strata. We have people from good rich families who suffer from this. PG, I had some salad somewhere a couple of years ago or a couple of months ago, and then he developed seizures, and that is because of the NCC component. Some people don't even bother to find out. You see, it requires a bit of medical and science based orientation to understand this. So next time you go to any joint, insist always, gloves have to be there, irrespective of whatever you are doing, because otherwise, like handling of food, people are touching their phones, man. Like you go to a pizza shop, now the guy is making pizza, he's handling phone, he's carrying the same phone in the toilet also, no? So, I mean, like what I want to say is that all vegetables in India should be washed very thoroughly. We bring vegetables from the market, keep it in the refrigerator without washing lots of time, no, out of alas or out of lethargy. That should never happen because fecal contamination is there. Next, we talk about subarachnoid hemorrhage, and the condition is very easy to pick up because in the MRI head of this patient, you can notice the very classical finding of unmistakable star of death. Star of death occurs because there would be blood accumulating in the basal cisterns. Due to gravity, the blood will go down. There's a berry aneurysm present in this guy which has ruptured, which is causing this radiological finding of star of death. Where I'm putting the yellow marker at the moment, this yellow marking that I have currently done is basically presence of blood in the Sylvian fissure. So don't always rely on the star of death in the question. Sometimes the star of death may not be visible on a CT because it may not be very gross bleed. It could be even blood in the Sylvian fissure. So these are two very classical radiological findings for subarachnoid hemorrhage. Now, in these patients, if we do a lumbar puncture, usually we do a lumbar puncture, I'll teach you the algorithm. But if you take the lumbar puncture, if you do lumbar puncture of this patient and take the CSF initially, it might be having slightly a reddish appearance because there might be RBCs present in the CSF. And in the same patient, the tint, reddish pinkish tint is present because RBCs are there. And after few hours, when you will re-examine the CSF of the patient, the RBCs will begin to break down. And when RBC will break down, they will produce bilirubin, and bilirubin happens to be slightly yellowish in color. So I want to say that in these patients, now the color of the CSF will become slightly yellow. That is a lemon yellow or a yellowish tint to the CSF, that is called as xanthochromic cerebrospinal fluid present. The message here is, if you read a question that says bloody CSF, it could obviously be that herpes simplex encephalitis, but here the history will be different. The history will also be covered. RBCs in the CSF written, think in terms of herpes simplex encephalitis or subarachnoid hemorrhage. And after a few hours in the same patient, the RBCs cannot survive in the CSF, so they will break down, and that will cause a yellowish tint to the CSF because bilirubin is yellow, so xanthochromic CSF would be given. What has happened in this patient is a berry aneurysm that has burst, though the number one cause of subarachnoid hemorrhage is not rupture of berry aneurysm. If he says what is the leading cause of subarachnoid hemorrhage, it is trauma. Following trauma, it is rupture of berry aneurysm. In our cases, most of the time, the question will say, young lady, 20-30 years of age, she woke up with the worst headache of her life. Or the question might use the word thunderclap headache. Thunderclap headache means that it occurs without warning. Like I'm talking to you at the moment, suddenly I keep my pen and say, doctor, I don't think so that I'm well and I want to rest. And after 1 minute, you see me, I'm quiet and I'm just sitting with my hand on my head. And I'm like, I feel as if there's a volcano erupting in my brain. I feel so much of headache, sir, as if my head will burst. If that's the kind of description I give to you, that peak intensity, normally headache develops over a couple of minutes and hours. Headache developing peak intensity in 1 minute to 5 minutes, it's like peaking by 1 minute to 5 minutes, is what is called as thunderclap headache. So if an examiner is giving any of these two descriptions, worst headache of my life, thunderclap headache, then things will be relatively easier for you. Though I want to tell you that thunderclap headache can also be seen in pituitary bleeding, that is pituitary apoplexy. it can be seen with cerebral venous thrombosis. This is venous stroke. I'll talk about venous stroke with respect to OCPs. Like women, when they're taking OCPs, high dose of estrogen in the OCP can cause clotting of blood in the veins of the brain. That is called as cerebral venous thrombosis. That can also have a thunderclap headache. Then can be hypertensive crisis and acute hydrocephalus. So there are 4 causes for thunderclap headache apart from subarachnoid hemorrhage. Thunderclap headache is not an accurate way to solve a question of subarachnoid hemorrhage. Though a lot of platforms or a lot of people might be saying like this, that thunderclap headache written, your answer is subarachnoid hemorrhage. Man, I'm trying to tell you, thunderclap headache is not an accurate way. Thunderclap headache, I'll again say like this. I am sitting at the moment in front of you, talking to you. Suddenly I start holding my head and say I'm not feeling well. After 1 minute, I'm totally silent and I say, doctor, my head will burst. That's in peak intensity, man. I mean, pain rating 10 on 10. That's what happens in subarachnoid hemorrhage. You can notice the distress on the face of the patients. Literally, tears would be streaming down. That's the amount of headache they won't be able to explain. But this is also seen in pituitary apoplexy, bleeding in the pituitary, cerebral venous thrombosis, that is seen with OCP intake in a female, acute hydrocephalus and hypertensive crisis. So don't use it as the prop to solve the question. Both of these phrases look very good, but they're not good enough. What will be good will be what I say next. Young female woke up with sudden onset headache with nuchal rigidity. When I say nuchal rigidity, the query a lot of students is, sir, it can be meningitis. By meningitis will have fever now. Without fever to nahi hoga. Any question that begins with describing a young man or a woman with a few hours ki history of headache with nuchal rigidity, think in terms of subarachnoid hemorrhage. I put a star mark here to say that this statement is more accurate than the word worst headache of my life. Yeah, you and me also know, if sometimes we have very severe headache due to sinusitis, you and might also said, yeah, I never had such severe headache in my life. Sinusitis se bhi to pain bahut severe hota hai. Thunderclap headache, I've described multiple other scenarios also. So sudden onset headache with nuchal rigidity with few hours history is the usual presentation for SAH. Then he will say what is the next best investigation after CT-AD, क्योंकि CT-AD का finding तो आप बता ही दोगे. That star of death and blood in the Sylvian fissure has been asked so many times in both FMJ and NEET PG कि अब तो पूछना बंद कर दिया. Now I started asking what will you do next. This is a NEET PG MCQ. What will you do next in the patient? Your answer will be that I will be taking the patient up in the cath lab and I'll be doing cerebral angiography. This patient's family member, like this young lady, had subarachnoid hemorrhage, and you have told a brother that we'll be doing a cerebral angiography. So he's a very perplexed. He says, sir, I mean, she's so young and you're doing angiography of the brain, sir. Like, how will you do it? So said, we'll take a access from the groin femoral artery. We'll send up a guide wire from femoral artery into the descending aorta, arch of aorta, and then we'll reach the brain, and then angiography will be done. So he says that, okay, doctor, like you are talking about a very invasive process, cerebral angiography. What will you come to know from it? So I will tell him that I will be able to precisely localize that where is the berry present. He says that has already ruptured. I said, yeah, I know that the berry has already ruptured. I mean, like this is the berry aneurysm. Let me say the berry aneurysm has ruptured. The blood has escaped already into the meningeal space that caused that meningeal irritation. And now there is a clot which is organized here, because anytime you are bleeding anywhere in the body, there would obviously be a development of a clot present here. So the clot which is present here can get dislodged from this position. Again, bleeding can start, rebleeding can start. So after I have done cerebral angiography, in the same setting, I have demonstrated that there is a berry aneurysm present in any blood vessel of the brain. Then I will be deploying a wire here. This wire will be, this is like a platinum based wire which is deployed in the cerebral blood vessel of the patient. This will give structural support to the berry to prevent it from rupturing. So the line diagram that I mentioned in front of you at the moment, or what you can see superiorly, is the main treatment for this condition. That after doing cerebral angiography, what I will do in this patient is called as endovascular coiling. I'll write down the treatment separately also, but since this is marked here, so let's just do some markings in the diagram also. This diagram basically shows what is called as endovascular coiling. Endovascular coiling is the main treatment that is done for berry aneurysm that has ruptured, and a lot of these patients could be having more than one berry aneurysm. Like this patient was having one in the left anterior cerebral artery communicating with the anterior communicating artery, ACOM. It could be present in the right one also. The main treatment for this condition, this is the treatment of choice for subarachnoid hemorrhage. It is not nimodipine. Nimodipine is a drug treatment. I'll give you the rationale for this also, but the main treatment for this condition is endovascular coiling. When I was a student your age, then at that point of time, cath lab facilities were not so well developed. We could not even dream of going into a brain blood vessel and then putting a coil there and giving structural support. So at our time, the answer used to be aneurysmal clip. You can see this clip that has been deployed at the base of the berry. So it will cut off the blood supply and therefore the chances of rupture will be minimized. So there are two ways we can manage this condition. One of them is by the name of aneurysmal clipping. The disadvantage of aneurysmal clipping is that this patient can never get an MRI done ever in his life for any other medical reason, because if somebody is having an aneurysmal clip in place and you do a MRI, this clip can get dislodged from its original position and thereby like the berry will become vulnerable. But at the moment, my point is there are two treatments available. If we ask you to select one, always select endovascular coiling for this patient. The next best investigation after a CT head in this patient is cerebral angiography. The next question was again asked in INISET exam. He said, what is the next best investigation if the CT head is normal? Like if the CT head is showing star of death, if it is showing blood in the sylvian fissure, then the diagnosis will be relatively easy for me to make. But if the CT head is normal, then what should I do? Because I'm not having any evidence, then I will be doing a guarded lumbar puncture. When I do this guarded lumbar puncture, the findings that I'll be getting would be that of bloody CSF if I do it in the initial few hours. If I do it after 6 hours, for example, then I will not get bloody CSF. Then I'll be getting is a xanthochromic CSF in a patient. So there are two questions on next best investigation which have been asked in the exam, and in the MCQ in the ANICET he did not mention the word nuchal rigidity. He said Brudzinski sign. एक ही बात है ना, एक ही बात है, मतलब both are signs of meningeal irritation. The way you elicit them is different, but nuchal rigidity, Brudzinski sign or like Kernick sign, they all indicate meningeal irritation. Why there is a meningeal irritation? Blood is irritating the meninges, that's why. So don't be under impression that nuchal rigidity is only a feature of meningitis. वो तो ठीक है भाई, pus will irritate the meninges. Here blood will be irritating the meninges. Overall, the most common cause is trauma, but if I say young woman, she woke up at 5 a.m. in the morning with a very severe headache and she's having vomiting also, she's having nuchal rigidity also, then I will think in terms of SAH. I will be doing a CT scan that can show any of the two findings, blood in sylvian fissure or star of death, or for that matter of fact, like if the report is normal of CT scan because bleed is very chota and the CT scan may not be able to pick it up, no, not a problem, guarded lumbar puncture can be done. The first investigation to be done for evaluation of this patient has been elaborated and explained to you. That is a non-contrast CT head. So this is a revision slide. First investigation is NCCT. For any CNS bleeding, it is CT. Next best investigation after CT head is cerebral angiography. The objective or rationale is to localize where exactly is the bleed present, which blood vessel is where the berry aneurysm is present, and the most common location of the berry aneurysm, as you can see in the lower part of the slide, should be remembered as ACOM, that is anterior communicating artery, where it meets with the anterior cerebral artery. I've used a short form here. Most MCQs will also be using it. ACOM basically means anterior communicating artery, where it meets with. He may not write the full phrase, but I'm writing it though. Anterior communicating artery and anterior cerebral artery ke junction pe. What to do if the CT head is normal in a patient? If CT head is normal, then we will have to make a diagnosis first. So I will do a guarded lumbar puncture. The findings of guarded lumbar puncture have also been discussed. Initially, he may write blood in the CSF, RBCs in the CSF of pinkish color, and in the same patient, if the findings are like if the patient comes after 6 hours, then the RBCs would begin to burst and there would be a lemon yellow tilt present. The treatment of choice for this condition should be answered as endovascular coiling. And now, like, why is this slide important is he will say what is the drug of choice of this condition. So for the drug of choice, I would like to say the following facts. This is the berry. The berry had ruptured and the blood had leaked into the meningeal space, understandably. Then there was a clot that had developed. What I want to say is that whenever you are bleeding anywhere in the body, suppose you're shaving in the morning, you get a cut from a razor. Anytime there is a bleeding, then there is a spasm of the main blood vessel. The feeder vessel will undergo a spasm, and because of spasm, now brain infarction will occur, guys. Because every time there is any bleeding anywhere in the body, then there is always a corresponding vasospasm that occurs in the feeder vessel. And if vasospasm will occur, then there would be double insult, because initially he had bleeding and now there will be a vasospasm. That means brain infarction. Because of this brain infarction, the person may not even regain consciousness. So to prevent this spasm from occurring, I would like to also start the patient on nimodipine. This calcium channel blocker, however, is not available in IV format either in India or America. So most of the time, either we give it oral, or if the patient is drowsy, unconscious, then I will have to give it via NG tube to the patient. The main point is to see that you got me or not. Please tell me, why are you giving nimodipine in this patient? Are you giving it to control the bleeding, or are you giving it to prevent the resultant vasospasm? Your answer would be preventing the resultant vasospasm. The most common location of berry aneurysm is ACOM, anterior communicating artery, where it meets with the anterior cerebral artery. But if he says which location of berry is most vulnerable to rupture, then answer is PCOM. The posterior communicating artery aneurysms are relatively larger in size. To make the question sound sophisticated, he may not write the word PCOM, he may write the word top of the basilar artery. अब ये जो PCOM वाली blood vessel है जिसमें berry aneurysm develop हो रहा है, let's say this is PCOM and there is a berry aneurysm which is developing, then posterior communicating artery के साथ साथ में oculomotor nerve is also traversing, where the PCOM, like this is posterior communicating artery berry aneurysm that I've shown. Along with this, granulum number 3 is also traversing. So what will happen is, as the berry will become bigger, it will squeeze the oculomotor nerve, and therefore ptosis will develop on that particular side in this patient, with even pupillary involvement, because the fibers related to the pupil will also be affected. A question in the paper said, what is the most common cranial nerve involved in a ruptured or unruptured berry aneurysm at this location, that is PCOM? Then answer is third nerve palsy. Obviously, third nerve palsy is not valid for ACOM because anterior communicating artery is anteriorly located. So there, like there is no cranial nerve present, but at the PCOM location, third nerve palsy can be occurring in a patient. And then the leading cause of death in this patient can be any of the following. It can be bleeding, rebleeding, hydrocephalus, but the most important cause of death in this patient is vasospasm. It is a double insult. First, there was a bleeding, and then there was a development of spasm. Now, to make it sound sophisticated in the MCQ, he will not write the word vasospasm, he will write the word DCI, that is called as delayed cerebral ischemia. To make it sound sophisticated in the MCQ, he will write the word DCI, that is delayed cerebral ischemia, for the vasospasm, for prevention of which I had already given nimodipine to the patient. Because this is a very painful condition, there can also be release of, because of the extreme pain which is present here, he says that in these patients there is also release of a chemical or a cytokine from the ventricles of the brain that is called as B-type natriuretic peptide. Now what this B-type natriuretic peptide will do in this condition is natriuresis. नाम ही यही है ना, B-type natriuretic peptide, so it will cause natriuresis. Natriuresis की वजह से there would be salt loss from the body, and the sodium values of this particular person will begin to fall, because the sodium values in the body of this patient will begin to fall. So if the sodium will become less than 120, there can be development of seizures also. Electrolyte imbalance can contribute to seizures. Just to see that you got me or not, please tell me, why are seizures developing in this patient of subarachnoid hemorrhage? Is it irritation of the brain by the blood, or is it electrolyte imbalance? Yes, electrolyte imbalance. There is no irritation of the brain by the blood that is causing seizures there, guys. It is the electrolyte imbalance which is contributing there. Irritation of the brain by the blood is seen in intracerebral hemorrhage, but here it is an electrolyte imbalance. So don't be surprised if you read the word dyselectrolytemia written in complications of subarachnoid hemorrhage. And for the seizures part, I'm saying that this can be added to the clinical domain also. Like I told you, anybody with sudden onset headache with nuchal rigidity is always subarachnoid hemorrhage. But don't be surprised that in some MCQs there might be mention of the word seizures as well. I'm writing plus minus to say that seizures may or may not be present in patients of subarachnoid hemorrhage. Just say that once again, guys, without looking at the notes. Why are you having seizures there? Is it irritation of the brain by the blood, or is it dyselectrolytemia? Precisely, it is a dyselectrolytemia which is contributing to this. So from the brain hemorrhage perspective, the core thing that is always asked in the exam, from medicine domain is subarachnoid hemorrhage, for which endovascular coiling is the main treatment. The next best investigation after a CT scan would be a cerebral angiography. And now we talk about some questions which are from the surgery domain, like this diabetic patient fall in the washroom and the head slams against the wall. Lucid interval was noted. On reading the word lucid interval, don't answer subdural extradural, because lucid interval दोनों में होता है. It is found in subdural also, it is found in extradural also. So what we will focus is on the CT scan and the findings that are present. Like the son of this patient is saying that my mama is very irritable. She keeps on sleeping for most part of the day after the fall. You see, he says my mom is like very religious. She gets up and she goes to temple every single day. She takes a bath in the morning. But I don't know, I've never seen my mom sleeping at daytime. No, she's always working in the kitchen like elderly people are. And he says my mom, who's a diabetic, is sleeping for most part of the day. She's having headache, she's having trouble speaking, and she's forgetting things. So he brought her to the hospital. When we did a CT scan, I'll just enlarge the view. This is the left and this is the right. So one, you can notice the subperiosteal bleeding. So like she fell in the bathroom on one side, so there's a subperiosteal bleed and there's a countercoup injury. Now when you look at this countercoup injury, you can notice its shape is very, very peculiar. The shape here is concavo-convex. So the moment you pick up the shape of the bleed here, which is concavo-convex, you know that you're dealing with a subdural hemorrhage in this particular case. So the answer or the interpretation of this particular case would be, the case is brought on third day. On the right hand side in this patient, there is a concavo-convex hyperdensity. So I am using the word right-sided acute. Why I'm using the word acute is because the bleed is white. If this patient had come to me later, then this area will not be white, it will be black. I'll show you that CT scan also, then I will say chronic. Because it is white, I'm saying acute. 3 days also acute, and then I mean days also telling me it is acute, and also the color is also telling me that this is acute. And because it is concavo-convex, so the final answer for this question is right-sided acute subdural hemorrhage. So sometimes it can be a spot diagnosis that you have to make. This right-sided acute subdural hemorrhage, how did I work out the word subdural, is on the basis of the shape of the bleed present here, that is concavo-convex. I will be explaining to you biconvex bleeding also, that is called as extradural hemorrhage. And I repeat my statement once again, lucid interval is usually a distraction in this MCQ. This is the reason for error, that lot of guys just read the word lucid interval, diya tha sir, main to extradural maar diya. Extradural is for based on CT scan and not on the basis of lucid interval. Lucid can be seen both in right acute subdural hemorrhage and in extradural hemorrhage. Once the diagnosis of the patient has been made, now he will say what will you do for treatment of this condition, where there is like the source of bleeding in this case would be the veins. Like the source of bleeding in this case is the cortical bridging veins. So that is why the patient is being brought on the third day. In extradural hemorrhage, it is middle meningeal artery. So the patient becomes or comes to the hospital relatively early. For management of these patients, he says what is the main management that is to be done. So we will have to do a craniotomy in this patient. So emergency craniotomy would be the main treatment. In the MCQ, decompressive hemicraniectomy will also be given. We don't answer decompressive hemicraniectomy. It is a craniotomy that should be done. This is a decompressive. This procedure will also be in a sense decompressive only. But the point is you are removing the bone flap. But you are not like you will put the bone flap again back on. No, like when I say the word decompressive hemicraniectomy, we remove the part of the skull, but we don't put it back again. Like I'll give an example. Like there was a bomb blast in Delhi recently at Red Fort. Doctors had done it, right? Couple of doctors, they got, the guy was a cardiologist, man, and he got like those Pakistani handlers somehow modulated him ki zindagi khatre mein and whatever, and that guy, he used urea for that blast. So victims of that bomb blast, some of them were in like ICU for 2 months, because they were like maybe 100 meters away from the bomb zone, but the shock wave of the bomb can result in bleeding in the brain. So those patients developed malignant cerebral edema, and because of this malignant cerebral edema, the bone flap was removed, but the swelling in the brain was so much that they could not put the bone flap back again. So they put the bone flap of the patient in the peritoneal cavity. वो जो bone निकाले ना, that is put in the peritoneal cavity, and you do dressing and cover that area, and then when the swelling in the brain will come down, maybe 2 weeks, maybe 3 weeks, 4 weeks, whatever, when the swelling in the brain will decrease, then the bone flap will be put back again. So meaning of the word decompressive hemicraniectomy is that it is done for malignant cerebral edema. Malignant cerebral edema is what you read with respect to either hemorrhagic stroke or maybe let me say a patient who's a victim of a bomb blast and is like outside the radius of the splinters. You know, the bomb फटता है तो उसके जो sharpnels होते हैं, they rip the body apart. So the guy is within 100 meters of the bomb zone, I mean the body would be torn into pieces. But if he's away from 100 meters, then the sharpnels did not reach him, but the shock wave of the bomb can cause a bleed in the brain. It can cause swelling in the brain, and the swelling will take couple of weeks and months to die down. So that is decompressive hemicraniectomy. But in this patient, we're not doing a decompressive hemicraniectomy. We're doing a craniotomy for this patient so that we can ease off the pressure. What is doing here is you remove the bone flap, you incise the dura mater. Below the dura mater is the bleed. So the surgeon will do irrigation. So that brown blood के clots निकलेंगे. That is because the blood had clotted. Over 3 days हो गए ना, तो blood would have clotted at this point of time, and this was pressing on the brain. That is why this lady had become unconscious or was becoming lethargic, forgetful, and like later on she can have a brain herniation as well. On the left side, what you're seeing is a subperiosteal bleed present. Subperiosteal bleed present. Now suppose if the same patient will come to me later, and this is the CT scan, you can notice this is still the left and the right side respectively. And you can notice that now the shape, I mean the shape is the same, but like this is black in color, this is black in color. So now I will use the word chronic subdural hemorrhage. So let me just write down the data for this case also. What I've described at this moment is a patient who came relatively later, like diabetic patient fell in the bathroom, head slams against the wall. Over the next 3 weeks, the patient becomes very forgetful and delirious and has now been brought to a CT. Head was done. So I will say the person is having right-sided. Obviously, like the left and right side, you will not have an issue. Then is the word chronic. Chronic is because the area is black in color. Instead of writing the word black, now I'm using a technical word, hypodensity. You would be also noticing the fact that whenever MRI was being discussed, then I was using the word intensity. In MRI, I was using the word intensity, but in CT scan, I'm using the word density. I'll say this once again. In MRI, we use the word intensity. In CT scan, we use the word density. So this is right-sided chronic, and the shape is still concavo-convex only. So this is a right-sided chronic subdural hemorrhage. The prognosis in this case is even worse because the pressure in the brain, like 3 weeks, the pressure will rise even further. So here, if he says what is the main intervention that would be done, then your answer would be given as Burr-Hole surgery. The mortality rate with like subdural hemorrhage of the chronic variety can be as much as 40%. So he says Burr-Hole would be done. Lot of students answer ulta. They answer Burr-Hole for acute and they answer like a craniotomy for chronic. No, in chronic the prognosis will be more bad. So he says no faida of doing craniotomy. Every procedure there has to be some benefit present. So there's no benefit present here. That's why like we say we prefer doing a Burr-Hole in this patient. The Burr-Hole surgery in this patient would be done from the TRION. Though this aspect is discussed in surgery, I still find people making mistakes here, which is why I decided I decided to get into this. But obviously, like I myself will not be handling this patient, and it would be like a neurosurgeon who would be handling this patient. So Burr-Hole would be the best way for management. Next is the case of a guy who was driving under the influence of alcohol. He slammed the car middle into another vehicle, nasty crash, and then this guy is admitted in a hospital for 3 days. The guy is in coma and is not waking up. His father is saying, sir, you are not doing anything, because non-medical people think head injury hua hai to patient should be operated upon, but this bleed, there is no operation available. The CT scan of this patient is showing this chota bleeds. Like you can see this punctuate hemorrhages which are present at the junction of the gray matter and the white matter. I mean, outside is the gray matter and inside is the white matter. So at the junction of the gray and the white matter, at the junction, I'll just use a white color to highlight that. Okay, so the bleed is already shown, those punctuate bleeds. And then what I'm saying is that at the junction of the gray and the white matter, like he will use this theory phrase, bleeds, punctuate bleeds present at the gray matter white matter junction. And ये तो भी अच्छा कि CT scan is showing the bleed. No, sometimes CT scan can be normal also because the bleeds are relatively smaller. The main thing is the non-contrast CT head of this patient shows punctuate bleeds or micro bleeds, I can say. They're small at the gray matter white matter interface. Now the question for you guys, without checking out the notes, on basis of your surgery knowledge, please tell me, would you like to say this is traumatic axonal injury, or would you like to say this is diffuse axonal injury? Punctuate bleeds at gray matter and gray, and in fact I can write it this way, gray and white matter interface. Just like earlier I was saying na, that neurocysticercosis lesions are at the gray matter white matter interface. Right here it is punctured bleeds at the gray and the white matter interface. Yes guys, quickly, what will be the answer for like the diagnosis of this condition? Traumatic external injury, or would you like to say diffuse? You will say I will do counting. If the number of bleeds here, I'll just remove all these arrows. Let's look at these white spots here. I can put pointers here. This is like 1, this is 2, this is 3, this is 4, this is like 5, 6, maybe even more. Multiple punctured bleeds are present in this guy at the junction of the gray matter and white matter. So if 4 or more than 4 bleeds are present, if at least 4 or more than 4 bleeds are seen here, these are 4 or more than 4 microbleeds visible at the gray matter and the white matter interface, then you will say you're dealing with a case of diffuse axonal injury. Suppose in this MCQ CT scan was normal, or suppose maybe 1 bleed or 2 bleeds were present, then I would have answered it as TAI, that is traumatic axonal injury. Both are given in MCQs guys. Diffuse axonal injury is also given and traumatic is also given. Anytime a guy is driving a car fast not using a seat belt, this could be a nasty impact where the coma might be going on for maybe 10 days, 15 days, maybe 1 month. His father is arguing, sir, 1 lakh rupees per day ICU care, and you're telling me my son will not regain consciousness for maybe 10 days, 15 days. You guys are scamming me. Non-medical people are thinking we are deliberately keeping his son under sedation and intubating him because they think that maybe the hospital is trying to make money. We are not trying to make money unethically. It is that the guy will take time to come out of coma. Till that, you have to secure the airway. So we have to put the person on a ventilator. So diffuse axonal injury is the answer in this case. I can also write the second term, TAI, traumatic axonal injury. If they give you a CT head, non-contra CT head with a similar kind of history of a car accident and CT head is normal, then answer would be given as TAI. Another question to you guys, radiology/medicine. If CT scan is normal, you and me as doctors can understand it as traumatic axonal injury, but family members will not be ready to accept that. They will say it's a CT normal and how do we know this is not a scam? So a special test that can be done in this patient is SWMRI. SWMRI stands for susceptibility weighted MRI. This susceptibility weighted MRI is the best way to be sure about the diagnosis of traumatic axonal injury. I'm just putting a line to say, if he says what is the best investigation, don't answer DWMRI. It is not a diffusion weighted MRI. I'll discuss diffusion weighted MRI also for stroke. For traumatic axonal injury, the best one is SWMRI. What does susceptibility weighted MRI can see, what other MRIs can't see, is the hemosiderin deposits, because when there are very chota microbleeds present which are not visible on a CT scan, the blood will break down, hemoglobin will break down to produce hemosiderin. So susceptibility weighted MRI would be done. For this condition, if he says what is the management, it is conservative management. That is, I will have to intubate this patient. This would be a cuffed endotracheal tube to prevent any chances of microaspiration. The cuff pressure should be about 30 centimeter, and then I will have to put the patient on positive pressure ventilation. So routine ICU care is what is required. Care of the back, care of the bowel, care of the bladder, because if he will keep on lying in the bed like this, he can end up with bed sores also. He can end up with UTI also, fecal infection also. So good medical care is required, and gradually, spontaneously, these patients may recover. But when will they recover? No doctor can comment on that. That's like by chance. That person might recover after 1 day only, or some patient might recover after 15 days also. Then is the classical question that always comes with respect to the biconvex bleed. Like in this case, he has described a guy was hit on the head by a cricket ball, so he became unconscious. So the match was stopped. Everybody is crowding around this guy, and by the grace of God, the guy became conscious and he said that I will play. The referee or the umpire should have cancelled this guy's playing and said, retired hurt, go back and get a CT scan done. They let him play. After the end of the match, he told his coach, I'm having a headache, let me some rest, take some rest. Coach said, okay, sleep in the dressing room. Now the guy went to the dressing room, he slept, and he may never wake up again. If you get consciousness between 2 periods of unconsciousness, if you get consciousness between 2 periods of unconsciousness, that is what is called as lucid interval. This guy had first become unconscious on the pitch, but they let him play when he regained consciousness, and then when he went back to the dressing room, he again became unconscious and was brought to the ER. So lucid interval is present in extradural as well as in subdural hemorrhage. But how do you decide? You decide on the basis of this biconvex idli shaped. I can call it a idli, like biconvex, right? Very classical, or lens shaped. So It is the CT scan which is of paramount importance that tells you what is the type of bleed that is present. This is a lenticular idly shaped hyperdensity which makes the diagnosis of this patient very clear. What is the diagnosis? This is left, this is right. So this time my patient is having a right-sided extradural hemorrhage. You guys comment without checking the notes. What is the treatment for this condition? The source of bleeding in this case is the middle meningeal artery, which is a branch of external carotid artery. इस पे भी उसने परमुटेशन कॉम्बिनेशन बना दिया, मिडल मेनिंजियल आर्टरी ब्रांच ऑफ इंटरनल कैरोटिड एक्सटर्नल कैरोटिड. Guys, in the brain major blood vessel is internal carotid only, but this blood vessel is not a branch of the internal carotid. In the brain I agree main blood vessel is internal carotid, but this is not a branch of internal, it is a branch of external carotid artery. So middle meningeal artery branch of the external carotid artery. Yes guys, what is the treatment in this particular case? Your answer would be that you will have to go ahead with craniotomy in this condition also. But after doing craniotomy, we also need to do simultaneously ligation of the bleeder, because in any patient who is having an arterial bleeding, it will not stop on its own. So here the complete statement is decompressive, like he might say decompressive hemicraniectomy also. But the more appropriate procedure is remove the bone flap. The bleed is extra outside the dura mater, so it will be removed. But if I close the skull just like that, bleed will start again. Arterial bleeds are not going to stop like that. No, the artery would be pulsating. So we need to go ahead with ligation of the bleeder. So the complete answer in this particular case is craniotomy with ligation of the bleeder. So some of the aspects that I've discussed are overlap from surgery, but then they're just to emphasize that for examiner, it's not a medicine or a surgery case. It's just a case for them. He says in the casualty, you are the intern on duty. Identify on the basis of CT scan and presentation. What is the presentation? What is the cause of bleeding? What is the source of bleeding? And what will you do? What will you do is the most important thing for each of these topics that you study.